Prostate cancer. Prostate cancer. I repeat, prostate cancer. Please, take the time. I have taken 4.5 hours to make this presentation. Kindly listen attentively, go through it. Help yourself, help your friend, help your dad or grandpa, help your uncle, help your husband. Take the time, kindly listen to this, learn, and take appropriate actions and be safe. Thank you. You are welcome to my channel. Thanks for visiting. Today, I will be taking you through a lengthy presentation, and it's all going to be on prostate cancer. I have tagged this prostate cancer A to Z. Why that? Everything you need to know about prostate cancer, even the very difficult diagnostic process, have all been simplified here. The signs and symptoms, all simplified. Different types of treatment, including associated complications of each, all stated clearly here. Do you want to know if you have risk factor or factors for prostate cancer? Check here. So everything you need to know about prostate cancer is right here. This is a condition that should be addressed early. No, everything about prostate cancer is controversial, kind of. But by the time you'll be done listening, you will have no more questions to ask. Without further ado, relax. The journey is long, but it's going to be beneficial. All men should listen to this. All women should listen to this and pass it to the male ones in their lives. I appreciate it. Remember to subscribe along the line or when you're done. I appreciate it. Okay, let's get to the business. Prostate cancer. You know what this really stands for, right? Now, we can ask ourselves the question, why the need for this presentation? Why should I continue to listen to what this man will talk about? What is this prostate cancer all about? Why the stress? Oh, don't worry. Lung cancer is the common cause of cancer death in men. Do you know the second type of cancer that could be responsible for cancer death in men? The answer is prostate cancer. So, it is helpful if we know everything about prostate cancer and then go on with our life without bothering ourselves about prostate cancer anymore, or we'll start the screening at the appropriate time. Let me go through the first note here. Nothing is fixed about prostate cancer. The pieces of information we are going to get here about prostate cancer will go round and round and round. Then we'll get to the final bus stop. It is all over the map. Some will say it is all over the place. But I will do my best to make sure we navigate rightly, and get to the conclusion about prostate cancer. In other words, we will get to how to make definitive diagnosis of prostate cancer. Prostate cancer could be tagged as a silent killer. in the sense that it can kill you. But prostate cancer will do so silently, and whether it grows very slowly. Some people can have prostate cancer in the next 10 years. They will have no headache, but it could metastasize, get to some other parts of the body, and at that stage, curing it will become a mirage. It affects black men disproportionately more than all other men from all other races in the world. Get these facts right. All men who have prostate cancer. Black men will suffer more than the rest around the world. However, prostate cancer is worldwide. It's found worldwide. My advice is you follow the protocol in your jurisdiction after listening to this presentation. The information here, the pieces of information here is expected to bring the necessary transformation, and appropriate actions should follow. Now, dedication. I would like to dedicate this entire presentation to the memory of all men worldwide who have died due to prostate cancer. I'm going to pay special tribute to a learned legal icon who I knew very well. Not my patient, because I knew about the case from A to Z. It's someone very close to me who I had known years before he came down with prostate cancer. You know what? Brilliant, man, a legal icon, PhD holder, former dean of faculty of law, a man with the status of Supreme Court in his country, did not know that he was having prostate cancer. So, prostate cancer has no regard for your level of education or none of it, whether you are wealthy or poor, whether you are comfortable or homeless. There's no regard for that. All that is important is through this presentation that you are one of those who must go for screening quickly. If not, by the time this slow-growing cancer will be discovered to be in your body, it might have gone beyond the point of remedy. It might, like point of no return. No. Okay, this legal expert or lawyer, attorney, or whatever you call in your jurisdiction, the first sign that he picked was frequent falls and weakness. He approached his physician. He started working on what was responsible. Now, along the line, they picked that metastasis has already occurred, affecting the bones. Imagine that. So, he died. He died. Not because he was poor, not because he didn't have education. He died because the slowly growing cancer got him, because the cancer spread beyond the prostate gland, metastasized to all over the body before being diagnosed. And at that stage, no remedy. So listen to this presentation and learn one or two things, then start leading the campaign against deaths due to prostate cancer. I would advise that all men will listen to this. Listen to this and pass it to your friend, to your brother, to your nephew, to your son, uncle, father, grandfather, great-grandfather, and even pass it to women who will help their husbands, their sons, their fathers, their uncles, their brothers as well. Don't wait for the symptoms. And someone will ask me the question, why that? Like I said, this cancer will grow slowly. And all you could pick most of the times will be lower urinary tract symptoms, symptoms of obstructive uropathy. Now, I will get into all the symptoms in a bit, so I'm not going to take all your time right here. Then some other people who are unlucky, like the legal icon that I knew very well, will pick the first symptoms the first time when it has already metastasized, like falls, frequent falls and weakness, pain, confusion, even anemia. So for that reason, please don't wait for the symptoms before you approach your physician on the way out, not to die due to prostate cancer. Now, screening. I had a story of a family who said they will sue their father's physician who came down with bad stage of prostate cancer and no treatment could help, and the elderly man died, and one of the daughters said, we're going to get the family physician sued for not screening for the prostate cancer before the bad stage that our father was diagnosed with. Now, when it comes to screening of prostate cancer, I'm not defending the physician, but I'm telling you the facts that you cannot blame that physician too much for the following reasons. In medical world, we have timetable and routine screening times for cervical cancer, for breast cancer, for colorectal cancer, and the list goes on. But for prostate cancer, no. In fact, what you're going to get through this presentation is that there is argument for screening, an argument against screening for prostate cancer. To those who are arguing for screening of prostate cancer, will say this. One, since there is no symptom per se in the early part of prostate cancer, then screen. Second, they will say, if you pick prostate cancer early and treatment is embarked upon, with some other interventions, that can help greatly, and the man will eventually die of another cause, not prostate cancer. 3, if signs and symptoms are pointing to lower urinary tract symptoms, then why not having prostate cancer screening done? And be sure it is not BPH, it's not urinary tract infection, it's not prostatitis, it's not exercise or trauma, and so on. Okay. In addition to that, when you have screening done and you are picking high level of PSA, the argument for is that is good. That would trigger further investigations like rectal ultrasound, then you will be able to determine whether we should have biopsy and have definitive diagnosis and be able to help the man out early in time. Also, for screening, when someone has been diagnosed with prostate cancer and he is on the treatment, screening will help in monitoring. There's no fight, there's no quarrel over the last part that I've just said. Once somebody is already definitively diagnosed and is on treatment, then there's no problem about screening. Then everybody will agree that that would be screening. Okay. Now, let's see. Some people will argue against screening, and they have more points than those who will argue for. Now, what do they have to say? Argument against screening for prostate cancer. Number one, the high level of prostatic specific antigen is not a guarantee that it is prostate cancer. Whether there is false positive and only 25% of high level of PSA is truly prostate cancer. When PSA is pretty high, it could be urinary tract infection, it could be as a result of BPH, could be as a result of digital rectal examination done, or because the man had already just had ultrasound done, transurethral ultrasound, or this man had just finished exercise like biking before the sample was taken, or because of biopsy or trauma affecting the prostate gland, or because it's a warmer climate, or the individual are just ejaculated. So all these things could lead to high level of PSA. So those who are arguing against will say you are wasting your time. The value of PSA doesn't mean the person is having prostate cancer. Okay. Another reason why they are saying no screening, that is argument against, is we can have false negative. So when you screen and the PSA level is low, that doesn't rule out prostate cancer. Let me pause and rewind myself here. So you have taken the sample of PSA, it's been assayed, and the result has come back and PSA level is low. Don't tell the patient, congratulations, sir. You know why? About 10 to 15% of prostate cancer will not produce a high level of PSA. Wow. Wow. Another argument against is we can be overdiagnosing. We can be overdiagnosing. Why that? You might be diagnosing a man with prostate cancer, and it may not be the type that is very harmful. It might be the type that the man can even live with and die a natural death after. Then, near having that meeting and declaring to the man that I'm sorry to declare this to you, that the biopsy had come back and then you are having prostate cancer, will be enough to tilt him into depression, into anxiety, and that might be what will even kill the man. How about the stress of the treatment that may not even be needed in the first place, because the next 10 years If it's not the aggressively growing type, we'll get into different types later on, where differentiated, undifferentiated, and intermediate, we'll go over them. How about the loss of money and time, and the side effects and complications of every medication, chemotherapy, radiotherapy, hormonotherapy, they all have side effects. Why do we want to subject someone into all these things when the type of prostate cancer they have will not do them any harm for the next 10 years, and the man will even die before the end of 10 years, naturally? So that is why some who are arguing against are saying, you don't need to be subjecting people to unnecessary stress. Even when PSA has led to diagnosis, that may not change the chances of dying. I've said it. So people who argue against have so many points, but those who argue for, they've stated their points earlier. So listening can continue to listen and make up your mind by the time I'll be rounding up. Now, who should even think that he or she will need screening for prostate cancer? Who should even, should it cross the mind of everyone? I would say yes, for all men all over the world. But more now about the following people. If you are a black man or a man from the Caribbean, you should be thinking about it once you have lower urinary tract symptoms and the symptoms of obstructive uropathy. I will go into all those symptoms very soon. So I will just want to whet your appetite. If I say it here, you might end the presentation and then run to your doctor. So you'll get it in a bit. So you're a black man or you are from Caribbean and you're having lower urinary tract symptoms of obstructive uropathy. It might be BPH, it may not be. It might not be benign prostatic hyperplasia, it might be prostatic cancer. You are not black, you are Asian or white, or you have family history of prostate cancer in your grandfather, father, uncle, son, as the case might be, then you need screening now that you're getting older, right? 40, 45, you're 45 years old, and there's positive family history, you need screening. Okay? You are not black, you are Caucasian, you are Asian, you are Latino, Hispanic, and you are a man, okay? And you are greater than 50 right now, but with signs and symptoms of obstructive uropathy that I will get into later on, lower urinary tract, then you need to have that conversation with your physician that is it only urinary tract that infection that could give me this? Is it only BPH? Why can't we screen for cancer? Now, you have other form of cancer in your body. Maybe because you've been smoking for a long time, then you are down with lung cancer, no cancer elsewhere. Then you are greater than 60 years old now with other forms of cancer in your body, and you are having symptoms of obstructive uropathy, then have that conversation with your physician. There is no recommendation for general screening for the entire populace, unlike cervical cancer, breast cancer, or colorectal cancer. We don't have that here. Okay, you have agreed to be screened. The screening has started. the PSA is the result is back and it is high. Then the question is, okay, and so what? What is going to fall? Of course, many things will happen. I will go into that when we reach diagnosis. But just to whet your appetite right now, that high level of PSA is not saying you have prostate cancer immediately. We can't say that, but it is pointing to it. And also, low level of PSA is not saying you don't have prostate cancer. No. No doctor will tell you, oh, your PSA is low, congratulations, no prostate cancer. No, there's nothing like that. Because you can have prostate cancer and PSA is low. And then the next question somebody will tell me is, so why doing the prostate specific antigen at all? Well, I will tell you more when we reach diagnosis. So when PSA is high, we then do more tests. We do CT scan, we do ultrasound, we do MRI, PET, we can even do bone scanning, we do everything, and then determine if you are qualified for biopsy. So when the biopsy is done, reported, histologically examined, then glazing grouping and classification is written, then treatment will commence. Now, prostate gland is the main gland that we'll be addressing here, but is living in a community with some other neighbors, like renal system, gastrointestinal tract, and then when the cancer is moving around, it can go into the bones. Actually, it can spread anywhere, so all systems could be affected later on when it's pretty bad. Now, I've just said it. So when we're talking about prostate, the prostate will be somewhere here, but see the neighbors. This is adrenal gland. We will talk about this when it comes to hormonal therapy, okay, and the production of testosterone. This is the kidney. You can see the relationship between the kidney, the ureter here, that will pass the content from the kidney into the bladder, and this is the bladder neck, where the prostate, will be sitting, okay, will be located. So the urethra will pass through the prostate also. The urethra will be compressed by the enlarged prostate, just as it's going to compress the bladder neck and the nerve, bundles around. So the urethra, TH, is different from ureter. Ureter is coming directly from the kidney into the bladder, while the urethra, TH, will take it out. Okay, so you can see the organs that are pretty close. We cannot see seminal vesicles here. No, I'll go into that in a bit. Now, there's no way we can talk about prostate cancer in details without referring to the gastrointestinal tract, particularly the large intestine, the anus, the rectum. Now, someone will ask, why bringing that skeleton here? Just to let you know, when we talk about metastasis, and we say metastasis to the bone, so it can spread everywhere. Now, the spinal cord is right inside the vertebrae, yeah? And even the brain can be affected in the central nervous system, right? And then, the entire skeletal system. Now, the prostate gland. This is one major buster along the journey of full information about prostatic cancer. Don't mind my sketch, I'm not a good artist. You can see the bladder here, okay? And just below the bladder, now the bladder neck, you can see down here, you will see the prostate gland itself, right? But you can see at this angle seminal vesicle. We'll talk about that later on. See the rectum and the anus. Now they are good neighbors, right? So from the anus, the probe of transrectal ultrasound could be passed, and the view of prostate is possible here. Okay. Then if you look very carefully, you can see the testes, right? Now, some will call it testicle. Okay. And on top of it is the epididymis. And from there, you can see the vas deferens. Now, the vas deferens will go through and reach the seminal vesicle, then empty into this long one called urethra, urethra, okay? And the urethra, you could see, is passing through the prostate itself. And then the urethra will go through the penile and then empty outside. So you have seen how the prostate can affect the flow of urine. Then we have obstructive uropathy. I will go into full in a bit while talking about signs and symptoms. Then you can see that the testes that will be producing now testosterone is not far from where testosterone could have affected the prostate gland itself. And then this is the reason why we'll be talking about reproduction in male and the problem with prostate cancer and the probability of erectile dysfunction and oligospermia, azoospermia, painful ejaculation, and even infertility. All because you have seen the relationship between the testes, epididymis, vas deferens, seminal vesicle, including prostate gland itself, that will produce one or two things to form the semen. So, yeah. Now, let me take you through some other things about the prostate gland. First of all, you need someone by your side from beginning till your full recovery when it comes to prostate cancer management. Now, the prostate gland itself is a sex gland in male, just like the testes or testicles, as you may call it, that are in Britain, UK or North America, just like seminal vesicles, testicles, and prostate gland. They are interrelated when it comes to male reproductive system. The prostate gland secretes fluid that will make up the semen just like seminal vesicles will do. Now, about the size of the prostate gland is just like the size of a walnut or ping pong ball. It is situated below the bladder. You can see right here. This is the bladder here, and this is the prostate gland. Okay. It surrounds the upper part of the urethra. That is why when it is enlarged, either as a result of benign prostatic hyperplasia or as a result of the cancer, is going to compress the urethra, and then the flow of urine will be appreciably affected. The prostate gland is affected by sex hormones, and then the sex hormones here will do few things. It can stimulate the prostate gland activities and also facilitate the replacement of the worn out cells of the prostate gland. So here, testosterone is the chief commander that will do all these things. And the testosterone is produced right here from the testes. Some could be produced by the prostate gland, while some could be produced by adrenal gland, but majorly produced by the testicles. Okay, uh, it's a small, organ, the prostate gland, but when it is enlarged, then it gives us a big problem. When it is first, before any cancer, it is going to be robbery. Now, what are the functions of this prostate gland? Uh, it's responsible, in part, for the seminal fluid production and plays a role in hormone production as well. It helps to regulate urine flow. You can see that when it is enlarged, it's going to compress the flow of urine. There may be some problems associated with this prostate gland, like inflammation can occur here called prostatitis. When that happens, PSA level will be raised as well, just as it's going to be when there's benign. Benign means you don't need to run around. It's not likely going to kill you. Benign prostatic hyperplasia, right? And then another problem here is what we're addressing today. Prostatic carcinoma can all occur right here, in the prostate gland. Now, let me quickly touch on, I've been talking about lower urinary tract symptoms, So when this prostate gland is enlarged, then there'll be difficulty urinating and the individual may be straining because you are forcing the urine through this bladder to pass through the enlarged prostate that is compressing the urethra, the one with, TH, urethra, that will allow the urine to flow to the, outside of the man. I don't want to be repeating the name of that organ. You know what I'm talking about. So, the individual will have poor stream or weak urine flow, and the individual after peeing will feel as if the urine is still retained inside the bladder, incomplete empty. Not just feeling alone, that is the reality, because it's not going to flow, fully. So weak flow or poor stream. Then bladder control will become poor somehow. So as a matter of fact, you have what is called urge incontinence. Then you can have hesitancy, you are about to pee, but you are afraid because it's difficult, it can be painful, so you hesitate to go to the toilet or washroom to pee. Then, because of this incomplete emptying, then you'll be having what is known as intermittent stream. It comes, stop, comes again, and then after you have peed, part of it will be dribbling, post-micturition dribbling. And then you'll be there, in the toilet or washroom for a long time, so prolonged micturition. All these are what we collectively refer to as obstructive uropathy signs and symptoms. But at the same time, when you now have urinary retention in the bladder for a long time and you can't get it out, there may be backflow to the ureter, that is without H, ureter. And that one will also go back to the kidney, giving us hydronephrosis. So when this retention is taking place, that may be urinary tract infection right here, and then you then have irritative symptoms on top of the obstructive symptoms. And then you have frequency, urgency, you have nocturia and dysuria on top. So in females, there is no prostate gland per se, but we have a lookalike, which is known as homologous structure called Skene gland, and that is SKENE, no, gland. That will secrete a whitish or viscous substance that will be released during, female, action. You understand what I'm talking about? I don't want to go into details of that. So there's no prostate gland per se in female, but we have homologous structure. They look alike. That is, formed, closely like the way prostate gland is being formed during embryogenesis. So the Skene gland can also secrete PSA in females and PSA phosphatase. Though it is very rare, but the cancer of the Skene gland may occur as well in females. It is related to something, and then I'm going to stop the details about prostate gland there. Like in men, it can serve as G-spot. Okay, so let's leave that as the detailed information about the prostate gland. Okay, I'm about to move away from the description of the prostate gland, but it will be incomplete without describing the histological zones. So the zones of the prostate gland. My poor sketch notwithstanding, pardon me, I'm not a good person when it comes to drawing. The important thing is passing the info across. So this is the prostate gland. This is the posterior part. The rectum is supposed to be somewhere here, and this is the anterior part. Okay. You can see the ureter coming from the kidney, dumping the urine in the bladder. The bladder is a sac, and here is the bladder neck. The urethra is going through. The TH1, right, is going through. Then anteriorly here is the fibromuscular stroma. That contains both smooth and striated muscles, and they form the internal and external urethral sphincter. That is fibromuscular, striated, and smooth muscle. Okay. Then we have the transitional zone. Remember the density the other time, right? And I said it's the part that surrounds the urethra. You see the urethra is passing through here, and the transitional zone of the prostate gland is surrounding it. This is the part that commonly becomes affected when we are dealing with BPH, benign prostatic hyperplasia. You can see why BPH could be very troublesome when it comes to obstructive uropathy, because when this is enlarged pretty close to the urethra, so easily it's going to compress it. That is transitional zone. Then we'll see the urethra. Okay, I'm getting to the peripheral zone. The peripheral zone is the largest of all the zones. If you just merely looking at it without even measuring anything, you can see that it is the largest. And it's right there at the back, posteriorly, okay, compared to the rest zones, right? So peripheral zone is the largest part, almost about 2/3 of the entire prostate gland histologically. Here, it is significant in the sense that it is located posteriorly. When I started, I said the rectum is supposed to be somewhere here. So when digital rectal examination is done, we are going to be feeling this. So the physician will feel almost the 2/3 of the prostate gland, but you'll be feeling the peripheral zone. So what about the other parts, of the prostate gland? And also another important fact about peripheral zone is This is where prostatitis occurs commonly, and from there, it's going to spread to other parts of the body. And can anyone take a guess why it is that so? Well, and someone else might provide the reason, but my guess is since it is posterior and pretty close to the rectum. You understand now? Okay, so um, prostatitis from here, digital rectal examination ourselves will give us the picture of what is happening here. You know, hard, craggy, whatever you pick. Then you can see the ejaculatory duct, right? That's not part of these zones. So it's not passing through here and obliquely connected here, right? Then the last zone that I'm going to talk about is central zone. You can see the central zone here, and is surrounding what I've just mentioned now, ejaculatory duct. That is the central zone. So finally, prostate gland has four zones: fibromuscular stroma, transitional, peripheral, central. Ejaculatory duct is passing through the central zone. The transitional zone is the one caging the urethra, while the fibromuscular stroma is supplying smooth and striatal muscles to guide the internal and external urethral sphincter. Thanks for listening. Let's move on. Now, risk factors for prostate cancer. First, the most important is genetics. As a matter of fact, molecular biology may likely rule the world in the next dispensation. In the area of medicine. Okay? Almost 90% of what we're battling with in health field is traceable to gene. So positive family history is very important, and it's a strong risk factor. Like gene BRCA1 and BRCA2, Lynch syndrome, check 2 ATM, all will be considered. Then the family history, if your grandfather, father, uncle, brother, or son have been diagnosed in the past with prostate cancer, then you have a very strong family history. So you're at risk of prostate cancer. Now, age. The older you become, the more the likelihood of coming down with prostate cancer as a man. Okay? Anything greater than 60. Then, if you have positive family history, start checking yourself at 45. Prostate cancer is pretty rare in anyone less than 40 years old. But with increasing age, the probability of coming down with prostate cancer increases. Race. I've said that it's going to affect any man anywhere in the world, but the black men will pay more for that. So when it comes to race, blacks mostly. I'm not saying Asians, Latinos, Hispanics, Caucasians are out of the wood, no, but blacks will pay more for prostate cancer. It's going to affect blacks more than the rest. It is possible in others, but let me repeat again, blacks will have the lion's share when it comes to prostate cancer. Another risk factor will be lifestyle. Someone will say, I can live my life the way I like. Yes, it's true. But if you're a male, and we're talking about prostate cancer, particularly you're from Caribbean or you are a black male, or you can't just live your life the way you like, particularly if you have positive family history, and then watch this lifestyle again. You're smoking, your chances is doubling for you. You're black, positive family history, and you're accumulating weight, decrease exercise, and increasing your stress, your chances is becoming greater and greater. Okay, how can diet affect the likelihood of having prostate cancer? Let me go through the good ones first. If you are on the following, or if you are taking the following, the chances of having prostate cancer due to them is low or is not there. Soya milk, moderate red wine, but it depends on how you define moderate red wine. Remember, the new research has shown that moderate red wine will not help your heart, unlike what we got to know in the past. So be careful when you are trying to help your prostate gland so that you don't run into trouble with your heart, with the cardiovascular system. So be careful with the red wine. Increase coffee, selenium, vegetables, and importantly, tomatoes. If you are not this, it will help you, to reduce the chances of having prostate cancer, or let me say, it will be beneficial when it comes to prostate cancer. Now, the danger when it comes to diet and prostate cancer will be, but not limited to, omega-3 fatty acids, multivitamins, red meat, animal meat. If you are not this, the chances of you having prostate cancer is increasing. Still on the list of what can increase your chances when it comes to what goes in your mouth will be dairy products containing calcium. If you are taking vitamin D, remember I've said multivitamins all the time, zinc, and your chances will be worse. You might go to some other literature and find some other items when it comes to diet that could affect prostate cancer, but these ones that I've given you are also on the list. Now, geographical location. Someone would say, how can geographical location affect the probability of having prostate cancer? More diagnosis of prostate cancer is now found in advanced countries. Let me say, because of more awareness and the technical know-how, the gadgets, the level of education, part of which I'm doing right now, because information brings transformation. So the record is there in advanced countries like Australia, United Kingdom, United States of America, the entire Europe, and Canada, that we are now picking more cases of prostate cancer in men. It's not that it's not happening in other countries, probably because of less awareness, less willingness to have investigations done, and then maybe because the records are not kept and the records are not accessible or easily accessible by others remotely. Maybe that is why we're not having the records. Maybe the countries that I've listed are doing all those things. That's why we have the record from them, to show that uh, more people have been diagnosed with prostate cancer nowadays. Another risk factor would be carcinogenic agents. So if you study anything you need to take in or environment you are, and there's a warning that this agent could be carcinogenic, you don't need to wait whether it will be prostate cancer or breast cancer or liver cancer. Just run away. So, meaning I cannot exhaust the list, but let's quickly go over some. When you are exposed to radiation affecting the pelvic region, either X-ray or any form of radiation to the pelvic region, can give you prostatic cancer. There's an agent called Agent Orange in Vietnam. In the olden days, I think around 1950 something to 1970 something, could be responsible. Arsenic compounds could be responsible. Some foods we take and the content of them might be responsible, like sugary drinks that can lead to increased body mass index, and that will later, be a factor in developing prostate cancer. Dairy products containing calcium will be responsible. So those who are taking excess calcium, if you're a man and you are taking excess calcium, okay, you can hear now. Vitamin D or zinc. Smoking, please just find a way to quit smoking, please, because smoking can cause so many cancers. Red meat, even it's not only red meat. Nowadays, research has proven it that even white meat like chicken contain a substance that could be carcinogenic when it comes to prostate cancer. Yes. Animal fat. Then this one will be interesting. Burnt meat, charred meat. You have barbecue and you like it when it is black, burnt or roasted to the point that you have black, and that's the one you like. You have had meat now. Increase weight or increase body mass index. Remember, research is now out that we will use body mass index less in determining health hazard, okay? But we will still be using weight, particularly the distribution of the weight, the distribution of the fat, like truncal obesity associated with all those things. Now, body mass index, increased body mass index around pelvic region might be associated with enlarged prostate. So, increased weight will increase the probability of prostatic cancer. Now, certain medications. When I'm addressing this, I'm not saying that the following medications directly will cause prostatic cancer, but it will worsen the symptoms of the obstructive uropathy. Okay? So, like you are taking diuretics, you are expected to be sending out fluid. Unfortunately, the tract is being compressed right now. So it's like you are sending water through a pipe that is narrow. It means you need more energy, or else you retain more fluid and that will go through, stay back into the bladder, go up into the ureter, and get back into the kidney, giving us hydronephrosis. Then we are done with renal failure, right? Anticholinergics are all anticholinergic drugs. Ipratropium, tiotropium, Benadryl, most of the antihistamines, tricyclic antidepressants, many of the antidepressants, and even vasoconstrictors like ephedrine, epinephrine, pseudoephedrine, over-the-counter nasal decongestants. Most of these antihistamines are anticholinergic. So all anticholinergics will have dry mouth and urinary retention with constipation as part of their complications. Remember, urinary retention with anticholinergics, now you are dealing with a condition that will not allow you to even urinate properly. So it's like double barrel, happening to the urine. So you are going to retain more urine. And of course, vasoconstrictor that I've given examples. Now, these ones will be negative when it comes to the symptoms of the obstructive uropathy that the prostatic cancer will cause. On the flip side is the 5-alpha reductase inhibitors like finasteride, dutasteride. What will they do? They will actually help. In fact, we use them in BPH, so they will make life easier for you. Now, non-steroidal anti-inflammatory drugs will make life easier, but will make life difficult. How will non-steroidal anti-inflammatory drugs make life easier? Anti-inflammatory, right? That's good. With anti-inflammatory effect, since inflammation is another factor that may trigger prostatic carcinoma. So, how about the fact that the anti-inflammatory effect will suppress the inflammation? So that is a plus, that's an advantage. But it says at the same time, we'll retain urine, we'll retain fluid. No, so we are in trouble. Okay, so NSAIDs will be both good and bad. Now, still on risk factors, but let's consider some hormones. Growth hormone, insulin-like growth factor 1, testosterone. Okay, don't let us rush to leave this page. Let's address testosterone the most. You have seen the diagram I showed you where the testis was located, and then the connection between the testis, epididymis, vas deferens, seminal vesicle, getting to the urethra, and the prostate also playing a part, in male reproductive system, right? Good. That testosterone is the powerhouse of food supply. How will I put it now? Well, is the one feeding prostate gland, testosterone. So when it is about hormonal therapy, all we are targeting is either to prevent production of testosterone or block testosterone from having affinity to the prostate cancer cells. We just don't want testosterone to reach the prostate cancer cells anymore, because once testosterone could be produced by any means and reach the prostate cancer cells, they will continue to grow. That is the food they like the most, testosterone. Then the testosterone when we cut it off, there's a separate definition given to that, and that is androgen. Remember, the androgen is the testosterone here. Androgen deprivation therapy. We are depriving the prostate cells, the prostate cancer cells, from getting testosterone. And that will be done through many means, like removing the testes, okay, hypothalamus, altering the message from hypothalamus, like this luteinizing hormone, releasing hormone, or getting anti-androgen that will block testosterone receptor directly. So we do that to cut off testosterone. Testosterone is pretty important as an androgen that can help prostate gland to grow or thrive. Now, another risk factor is the type of cells found in the prostate gland. We are looking at this, right? I'm not saying, no, this is prostate gland, no. But when we have high-grade intraepithelial cells in the prostate gland, then we are running into trouble. Because high-grade prostatic intraepithelial neoplasia will most likely lead to high chances of prostate cancer. Okay, we have left the region of risk factors. We are now inside the bus, now carrying on to symptoms and signs of prostate cancer. Interesting. Prostate cancer, mostly asymptomatic, I will address that, but when we pick symptoms later, none of those symptoms will be pathognomonic of prostate cancer. In other words, none of the possible symptoms will be specific. Unlike so many other conditions, when you pick a certain symptom or symptoms, then you can say, oh, this is the disease, right? In this case, you will not. Nothing is fixed. It's all over the map. Why that? Look at this structure again. If the cancer is limited to the prostate gland, it's not affecting neighboring structures, and you have symptoms, you still find symptoms of obstructive uropathy, difficulty pain, incomplete, micturition, and intermittent micturition, interruption, nocturia, and so on will still be picked. But you can't say when you are having that, then it is the cancer of the prostate that is responsible. Why is it that we can't say that? We can't say that because it might be benign prostatic hyperplasia. It might be stricture. It might be bladder and it might be cancer of the neck of the bladder. It might be stone in the bladder that is causing. Yeah. So if we move away from that, if the prostate is so enlarged and is affecting other structures around, now oligospermia or exospermia, it might not be prostate gland that is responsible. It might be testicular problem. Okay. Then if we are saying, okay, there is pain, pelvic region pain, what if The pain is associated with bladder, it's associated with a large intestine, rectum, and anal region. Could be. So when we start talking about the signs and symptoms, there's nothing specific that we will see and say, oh, because Mr. So is having that, then that is prostate cancer. No. Okay. I decided to put this here just to make it clearer about what we are getting into when it comes to the symptoms. So once upon a time, this man had apparent good health condition. So apparently well. That's why I say good health status. But the cancer, prostate cancer has come in, and then the condition is getting worse and worse. So like you're climbing up the ladder. And at the plateau here is the treatment. So the treatment will go to either one direction or the other, either good if we are picking the cancer early enough with appropriate intervention and good supportive system. So the person might come back to good health again. But if from good health the cancer was picked late and the treatment we could give would just be palliative, no hope of complete recovery, then we should prepare our minds and the mind of the affected individual that you are likely going to go down the ladder, meaning the condition will be degenerating more and more as days, weeks, months, will be passing by. And until we say, rest in peace. So, what are those things that we will be dealing with? Lower urinary tract symptoms, hydronephrosis, nerve compression, bone pain, spinal cord compression, thigh pain, gastrointestinal problems will affect hematology, reproduction will be affected, sitting will become uncomfortable, and affect the brain. Then the individual will get to this point, end of life, and then sleep, rest in peace. No, prostate cancer is that bad. But remember, if picked early and we embark on interventions, we might get the individual back on his feet. But if picked late and we can't, because it will reach a stage if it is bad before the diagnosis, there are so many interventions that we will skip. Like, you don't need surgery again for late stage. You don't need it. We just do the therapy, do some chemotherapy, and then continue palliative. You won't bother yourself about so many things anymore. So, this will inform the need for us to listen to this presentation again and make up our mind to see our physician. Now, the symptoms. Asymptomatic. Asymptomatic. Majority of people with prostate cancer will not have symptoms. And with that, this cancer will grow very slowly. And may never have any signs and symptoms until the individual dies naturally or dies of another cause. Okay? Okay. I think you can still remember my explanation on good health, but the condition is getting worse and worse, and then the diagnosis is made, that will be late. Treatment is not just going to ameliorate the entire condition and then back to the feet again. No, but degenerating and then death. The other side of it is the man was, once upon a time in good health, but fortunately we could pick the cancer early enough. Interventions were embarked upon, and is now back on his feet in good health. Now, we have moved away from asymptomatic. Now, somebody is now having symptoms. What is lower urinary tract signs and symptoms all about? Okay, number one, increased frequency of urination. The individual will be going to the toilet or washroom more than necessary. That is why I say nothing is pathognomonic here. This can happen in benign prostatic hyperplasia, can happen in diabetes mellitus, can happen with urinary tract infection. Okay? So, increased frequency and urgency. In fact, urge incontinence, we say. Then, when the individual gets to the toilet or washroom and is voiding, he won't be able to finish. He will think it was done, only to get up and get back again to continue. Incomplete voiding, because parts will be retained. Then, after urinating, there will be dribbling, post-micturition dribbling. At night, can be getting up to pee, that is nocturia, and painful micturition, dysuria. Then one interesting thing is while peeing, it will be interrupted. So the urine will come, will stop, will continue again, but this individual will even be straining to pee because there will be difficulty in peeing, in urinating. Then the individual will notice that the stream will be very weak. And at the point when the enlarged prostate is so massive that the urethra, that is with TH, have been compressed appreciably, then the amount of urine produced will drop, oliguria, very small amounts. Then when some people might not expect this, but it's a possibility. When it becomes so massive that it has compressed the urethra and it has been completely obstructed, then we can have anuria. Okay. At this time also, the urine will flow back when it's not getting out. Will flow back to the bladder, from bladder, go through the ureter without H, ureter will go back to the kidney. Then the kidney will start retaining the urine that is expected to be passed out, to be voided. So the kidney will become enlarged, hydronephrosis, water in the nephrons. Okay. And with that, retention of urine can serve as the incubating space for bacteria. And then we have urinary tract infection because there is urinary retention. And then we'll be dealing with irritative symptoms of the urinary tract. And that will be burning while peeing, pain while urinating, feeling of incomplete emptying, and there might be hematuria. And the feeling of pressure in the groin is part of lower urinary tract infection or obstructive uropathy. And then with irritative symptoms, with inflammatory process going on, with urinary tract infection now because the urine is staying longer than expected, there can be fever, nausea, vomiting, and discharge per the urethra is possible. And then the urine will be cloudy in color. So all these things can be going on when urinary system is being obstructed, obstructive uropathy. Now, reproductive organs will not be spared. Remember the diagram that the neighbors will include the testes, the epididymis, the vas deferens, seminal vesicles. So in men, when the prostate is in trouble, all those organs could be in trouble. And when they're in trouble, it's going to cause trouble for the man as per reproduction. So the man can start having painful ejaculation and can have what is known as erectile dysfunction, and then oligospermia in the sense that the vas deferens, okay, will empty into the urethra, but the prostate gland, when it is massively enlarged, can also occlude the vas deferens. I mean, at the point where it's emptying into the urethra. And with that, the reduction in the volume of semen that will get to the urethra and get out, to the appropriate place. And when that is massive, it can occlude it completely or even cut off the supply from seminal vesicles, then leading to azoospermia. So infertility is not far away here. So then, if this man is a young man, or not so young, but men can still produce semen, 60, 65, they're still fine, although the quantity will decrease with age, but you can still help this man if he still wants, offspring, children. Harvest this semen and bank it for him before, embarking on treatment, because part of the treatment may affect, erectile, it might cause erectile dysfunction and infertility also. So the best thing is from the beginning. Do you want to have more kids? If the answer is yes, and desperately so, then we'll harvest the semen and bank, search for him. Then certain medications for erectile dysfunction can be used after the treatment to enhance, performance. But recovery will be a factor of functionality of the man before the prostate cancer and the interventions that followed. You understand? Okay, let me explain further here. Someone that had been very active in this regard, now having prostate cancer, undergoing treatment, when recovery is expected, it's more likely that you will recover faster than someone who had not been so active before in that regard. You know what I'm saying, but I don't have to repeat it. So recovery is a function of pre-morbid functionality. The individual with higher functionality in that regard will likely recover faster than someone who had been weak before. Then you can use condom if your wife is pregnant. The reason is that if you have brachytherapy, and you don't want to pass the agent, the pellets of the radioactive agent into your wife and then cause teratogenicity and so on, then use condom, please. Don't make efforts to impregnate your wife until 2 years post radiation, because you can still pass the radioactive material to your wife, and teratogenicity is not good at any part of the pregnancy time, either first trimester, second or third, but it is worse and more horrible when that will occur in the first trimester. So the best advice is no effort to impregnate your wife until you have stayed 2 years post radiation. That is why we said we were advised that semen harvesting should take place and be banned. Okay? And once that is done, and your wife can use that for pregnancy, but the two of you can still be together all the time, but use condom. You will get rid of condom when you are 2 years after the last radiation to that pelvic region. Another problem is nerve impingement. Remember that the prostate gland is surrounded by the sides, flanked by neurovascular bond. So that has sympathetic, parasympathetic, and sensory innervation from inferior hypogastric plexus, and the bundle will travel through the pelvic floor towards the penile region, helping in erection. During treatment or in the process of trying to make the definitive diagnosis, the neurovascular bundle could be tampered with. We will get into that at appropriate time. But as per the signs and symptoms of prostate cancer, when the prostate is enlarged, it will have pressure effects on the neurovascular bundles by the flank. So in that case, the individual could present with tingling and pain. There may be leg weakness and sometimes falls and paralysis. Let me pause and explain here better. Remember, when I was giving tribute to that legal icon who had passed on, the first sign was frequent falling. It started falling down while walking. No, just walking to his vehicle, walking, around the legal office, and at home. So, leg weakness, frequent falls, paralysis can all happen because the prostate cancer is so big and is impinging on the neurovascular bundle. Then there may be urinary incontinence, fecal incontinence, and of course, erectile dysfunction. Another set of symptoms will manifest when metastasis has occurred and is affecting the bone, the spinal cord, and the brain. When it is about the bone, the individual can have bone pain, and the first sign of that might be thigh pain. And when it's affecting the vertebra, it's going to compress the spinal cord. And you understand what that may lead to. Paralysis, right? And even back pain. So there may be thigh pain, bone pain in any part that's affected, and pain while sitting down. Also, the brain will specifically give headache. Also, weakness of the part of the body, that the affected part of the brain is controlling. Okay? And just like in the case of nerve impingement, metastasis to brain to spinal cord can lead to frequent falls from weakness and paralysis. The gastrointestinal tract can present with decreased appetite. And you all agree with me that when there is decreased appetite, there will be decreased weight. Okay, so weight loss, decreased appetite. Also, still on gastrointestinal tract, there may be constipation. And you can easily agree with me, right, that the rectum is part of the navel, to the prostate gland. So when it is enlarged and the pressure effect is on the rectum, the large intestine, we are bound to be faced with constipation. That is one mechanism. Another one is this person has metastasis to the bones, nerve impingement, giving pain everywhere, and then you are giving painkillers, particularly narcotics. That on its own can give constipation as well. Now, hematologically, when there is bleeding, either hematuria or maybe as a result of the procedure or treatment or anything, and then we are faced with bleeding, particularly prostatectomy and everything like that, then we can be down with anemia. But before treatment, anemia might be the issue when there is massive hematuria. Now, symptoms of prostate cancer as it may affect the lungs. When metastases had reached the lungs, then the affected man can come down with cough. And the cough at this time will be worse at night. So some people might erroneously diagnose that to be asthma, because it was at night. The individual can also come down with shortness of breath, and recurrent pneumonia is another possible trouble. You remember, once there's a needle right there, then the bacteria may be able to thrive. Then there may be hemoptysis, and of course, pleural effusion. So someone with pleural effusion or hemoptysis is not always, all the time, that it is uh, primary lung cancer or tuberculosis. It might be secondary, cancer cells from the prostate. Other set of signs and symptoms will be tagged as tumor lysis syndrome. Um, I will not waste your time going through that here because there is a separate presentation on tumor lysis syndrome. If you want to listen to that, please kindly click on this very link. There may be paraneoplastic syndrome. Full info on that could be obtained through this very link also. Okay, we have learned before reaching this point that the older we become, the more the likelihood or the probability of having prostate cancer, particularly black men, though that is it with every man all over the world, regardless of the race. But this is another animal, right? With the type of bad one that we may not even do anything about. I mean, when it comes to treatment, that's what we call surveillance or watchful and waiting, right? Because the individual will not benefit so much when there are other comorbidities or life expectancy is less than 10 years. So we might not bother anymore. So the individual will be a good candidate for palliative intervention. So that will be end of life. Now, remember the ladder I showed you at the beginning of these signs and symptoms, like the individual is already going down. But if you want to know more about everything concerning palliative management, end of life, and towards the time of death, then there are two presentations here. If you click on this and this, you will have all necessary pieces of information, even beyond that of prostate cancer. Now, the diagnosis. At this juncture, I have an appeal to make because prostatic cancer is all over the map. Therefore, we will look for it all over the place. Meaning, there is nothing so specific to tell us that once we get this, then it is the cancer of the prostate. So we have a long journey. The biopsy is not the first thing to do. So how do we get to make that the decision or determination that this man should have biopsy done? So we'll start with what is known as PSA, prostate specific antigen. I'll go into details in a bit. What is digital rectal examination all about? You also know. Transrectal ultrasound, is that necessary? Is it useful? Will that help us? We will know. CT, we understand now many people is familiar with CT, right? Do we need it here? Don't be in a hurry. Bone scan, why that? We are talking of prostate down there. What's the business of bone scan here? I will let you know why. Magnetic resonance imaging, and we are putting PMRI. Let me whet your appetite. Do you want to find out what PMRI is all about? Don't worry, we'll soon know. Now, PET, what is it all about? And PSA, PSMA, PET, what is it all about? Don't worry, in a bit we'll get there. Finally, the decision to have biopsy is now made after going round and round and round. How will it be reported? The biopsy, how will it be done? Are there complications? When it's reported as glazing or TNM, to know the precise stage, whether the bad one or good one, we'll get into the details. Do we need other tests apart from all these ones? Remember, I have made reference to it that sometimes based on associated comorbidities or the age with life expectancy that is less than 10 years, we might just decide to watch and wait. Surveillance. But how are we going to make that determination without knowing other conditions in this man that will guide us to make such a final decision that we are not going to give any medication here? So you might have to do some other tests, or will be addressed here. So with that in mind, let's go and find out how your uncle, your brother, anyone, grandfather, grandpa, your dad, or yourself, who have definitive diagnosis of prostate cancer. Now, PSA. This is prostate-specific antigen. It is an enzyme, but of course we know that there will be a protein, right? Secreted by the prostate gland. Some said that it is a tumor marker specific for prostate cancer. I disagree totally. I disagree. Why that? You will soon know that we can have high level of PSA and the man is not having prostate cancer. Also, we will soon know that we can have low level of PSA, yet the man is having prostate cancer. Then someone will ask, what is the point of having PSA there? Don't be in a hurry. We'll get the facts. Now, let's address the facts. Prostate-specific antigen is a protein made by prostate gland epithelium, right? Normal prostate can make PSA, but in very, very small amount. Cancerous prostate gland can make PSA also, but sometimes we may not have high level of PSA yet the man is having prostate cancer. PSA is more in semen, but a good amount, appreciable amount is found in the circulatory system, in the blood. The PSA will help in liquefaction of the semen by breaking down the proteins formed from the seminal vesicles. There is no fixed level that is pathognomonic of cancer of the prostate. Medical students will enjoy this. There is no fixed level of PSA that is pathognomonic of cancer of the prostate. However, at a particular level, we may decide that other investigations should come, and that will guide us to having biopsy or not. But also remember clearly that low level of PSA may not rule out prostatic cancer. We only decide if other tests will be required to rule out prostate cancer when certain level of PSA is picked by us. For example, if we are getting 4 nanogram per mil or just greater than 3 nanogram per mil, we will call for more tests. Some establishments, some jurisdictions will even help the man by going lower, setting the bar pretty low to 2.5 nanogram per mil. That at the level of PSA of 2.5 nanogram per mil, more investigation should be done. Some authorities will put PSA between 4 to 10 nanogram per mil as the borderline range. Now, the mystery here is that higher PSA doesn't correlate per se with the presence of prostate cancer, while lower PSA is not enough to rule out prostatic cancer. It may be high, yet it is not prostate cancer. It may be low, yet it is prostate cancer. Then someone will ask, why this confusion? That is why the idiomatic expression had been stated earlier, that it is all over the map. But at the PSA of 10 nanogram per mil, it is more likely than not that we are dealing with prostate cancer, prostatic carcinoma. Now, some people will be interested, particularly medical students, in the PSA range per age. I'll give you the first year. A man between 40 and 49, if we are picking 0 to 2.5 nanogram per mil, we are fine. Compared to a man of 70 to 79, in a man of 70 to 79, 0 to 6 nanogram per mil is fine. In other words, the older you are, the higher the range of PSA in nanogram per mil that will be regarded as norm. This range could be lower in Asians. Black men at ages 40 to 49, well, black men generally are prone to having prostate cancer more than the rest. Caucasian will have a bit less than this value, for their own age group. And that will still be regarded as normal. While black men, they don't need to even worry about the PSA level. They should just go ahead with the full screening, particularly once there is positive family history of prostate cancer. So you are welcome on board. The journey has just started. PSA. If PSA is high and the individual is from the group, that's at high risk, like a black man with the uncle or father or nephew who had prostate cancer in the past, then we will not fold our arms. We will continue to have further tests. But with that said, let's go and find out more about PSA and how we can make diagnosis of prostate cancer. Okay, long journey. PSA, like I've said repeatedly, there is no guarantee that the value of PSA is telling us there is cancer or there's no cancer. Whether low PSA can still occur in cancerous prostate gland. High value of PSA may not be as a result of prostate cancer. So if we pick high level of PSA, if I'm saying today that it might not be prostate cancer, then what can it be? Okay, now let's go through it. High level of PSA may be as a result of cancer of the prostate, might be as a result of benign prostatic hyperplasia, which will not kill the man. It will only cause discomfort and associated trouble like hydronephrosis, urinary tract infection, and that might be what will kill the man. Okay? It might be because you are getting older. We've gone through it. Don't let me go back. High PSA might be as a result of urinary tract infection. High PSA might be as a result of digital rectal examination. The doctor has just done DR.BEN'S, and you now ask PSA and you are telling me in his eye. And why will you? I wouldn't even ask you for the value of PSA once the history of digital rectal examination has just surfaced in this man that it has been done close to the time the sample was taken. Urological procedures. Someone has just visited urologist, and then they've passed their equipment, the probe and everything, and then not long from that time, you have PSA acid, and you are telling me it's high. I won't even look at it because of this. So it could be cancer, but it may not be. Let's see other conditions when PSA may be high, yet it is not prostatic cancer. Someone will say, this is annoying. Why will you keep repeating this? I will be repeating it so that it will sink into the brain. So there's no guarantee that low level of PSA is ruling out cancer, please. So if you go to a doctor, the PSA level is low, don't go and be pumping champagne that I don't have prostatic cancer. It may not be. It may be the opposite. You may have it. Okay. So the PSA could be high in trauma to the prostate gland. So it is high, yet it's not prostate cancer. So that's why I disagree with those who said PSA is pathognomonic or prostatic carcinoma. No. It might be secondary to exertion, like you are a biker, you've just done with your biking, and the sample is taken, it's likely going to be high. We could see what I wrote here, right? I don't have to say that loudly. And might be as a result of this ejaculation. PSA could be high when there is constipation that is so massive or severe. In inflammatory processes affecting the prostate gland, known as prostatitis, PSA level will be high. Simple procedures, like the other time I said urological procedures, I just remember that some nursing students might be listening to this, and then maybe we'll skip just simple bladder catheterization. Bladder catheterization read through the urethra can also trigger the value of PSA up. Then parathyroid hormone high level can also correlate to high level of PSA. I put ETC because nobody knows it all. You might have some other points that I have not mentioned. So in other words, we have so many other conditions that can shoot up the PSA level, yet it is not prostatic cancer. But the low level of PSA is not the avenue or the good news to be celebrating that you don't have prostate cancer, because in terms of 15% of prostate cancer, we may not have high level of PSA. Now, still on diagnosis, since there's no guarantee about low or high level of PSA, if the result is bad, and the question is it high? And the answer is yes, it is high. Then what follows? What is the next thing to do? Okay, the first thing we can quickly think of right now is, should we begin serial PSA or should we make a referral? Okay, we've taken the sample. PSA result is bad. It's giving me concern, right? But not so much, not so scary. Then serial PSA will begin. So serial PSA begins. First thing first, we need to have baseline of the PSA value recorded today. Then, based on so many other factors, the age of the man, other associated comorbidities, we will start recording other values of PSA every 2 to 3 years. So every 2 years or every 3 years, you come back. Somebody will ask, why will you wait for a whole year or two? Prostatic cancer is not the type that grows very fast. But when you are back at the first 2 years, and the difference between the baseline and the sample taken is so significant, then I will run. I will not wait for another 2-3 years. Okay? So, baseline recorded today. Next 2 years, you are back. But depending on the value, I may not even wait for 2 or 3 years. I can say, come back next year. Since higher PSA is just a sign, when the PSA is high, it's giving us the clue that in the next 5 to 10 years, this man will start having trouble with prostate cancer. So it's nothing that's going to start early, except when it is the aggressive type, fast-growing type. But majority will be slow growing. You understand what I'm saying now? We will stop serious testing if life expectancy in this man is less than 10 years. So why wasting our time? Even if we make the definitive diagnosis, we're not going to do much. Because someone who, according to our books, will not live more than 10 years. That's what we do. Sometimes we understand how we make our uh, prognosis and then determination of lifespan and everything, which many times it has proven us wrong. Some will live exact time predicted, some before, majority will even live longer. Let's put that aside. But according to our books, when the life expectancy is less than 10 years, we will stop serial testing. Okay? If there is no other comorbidities to reduce the life expectancy, I will continue with the serial PSA testing. Once it is not yet scary and there are no other signs and symptoms anywhere, I'll continue doing this till the age of 70. When you have your 70th birthday celebration, then I'll give you my gift by stopping your serial PSA. Referral will be made when the level of the PSA is 4 nanogram per mil or more, 4.0 nanogram per mil or more. But I'll talk about that later. We can also refer if we're getting 3 nanogram per mil in a young man. Like I said, we'll put so many things into consideration while doing the serial PSA or even the baseline. The baseline today is 4 nanogram per mil. I don't need to do serial PSA. I will refer. Or the baseline PSA today is 3 nanogram per mil, and this is a young man. I don't need to risk the life of this man. I will refer immediately. Okay? Because referral will become irrelevant when the value, the baseline value is high enough when you compare to the age, particularly the race again of the man before you. We need to ask some questions. Have you been taking alpha reductase inhibitors? Some people will say, oh, why that? The reason is that if you're on finasteride or dutasteride, the medications, finasteride or dutasteride, can lower the value of PSA. You understand what I'm saying? Yet, we might be dealing with cancer somewhere, okay? Can lower the value of the PSA. But if you are on finasteride and dutasteride, and the PSA value is still rising while you're on this medication, the chances of you having prostatic cancer is pretty high. Let me explain further. You are an elderly man, or you have your father, or your brother, or your husband, or the grandpa, might even be your son, diagnosed with BPH, benign prostatic hyperplasia, and then the doctor has prescribed finasteride or dutasteride, and then you are visiting me, and I'm suspecting that we might be dealing with cancer, maybe because you're a black guy, and I will start the PSA, and the PSA is rising, despite the fact that you are on finasteride or dutasteride, and your PSA is still rising. I will refer you immediately to urologist for biopsy. You know why? That is a clue that you are likely battling with cancer already. There are some precautions to be taken while on serial PSA. We will make sure that you don't have digital rectal examination close to the time that we will take the sample for PSA. Also, we must have ruled out urinary tract infection, any urological procedures, advise you against biking, protect your perineum from trauma, even advise you to go on holiday away from your wife. You understand what I'm trying to say? I don't have to repeat it. And we will tell you to observe all this in about 2 months before you come for the PSA assay. This might be difficult for men. You understand what I'm saying? But it will be helpful so that we don't make wrong diagnosis, tell you that you have cancer, and you start all the expensive, traumatic procedures leading to definitive diagnosis or treatment when you don't need it. Then, when we've observed all the rules, and then the serial PSA is on, we will start observing some things. We will check the doubling time of the PSA. That is how long it takes for the PSA to double. For example, from 0.5 nanogram per mil to 1.0 nanogram per mil. Or from 1.0 nanogram per mil to 2.0 nanogram per mil. We want to observe that. Okay? Then we check for velocity. That is the change in level over the time. So is it that the PSA is 2 to 3 PSA over 12 to 30 months? You understand what I'm saying? So not necessarily doubling, but from 1 to 2 nanogram per mil or 2 to 3 nanogram per mil. Sorry for the interruption. Now, free PSA to total PSA. In the course of serial PSA, we will check that because it is going to be a good news when we pick more free PSA. More free PSA is likely as a result of non-cancerous cells of the prostate gland. So when we check the ratio of the free PSA to the total PSA, that could guide in determining biopsy or not. If free PSA of 50% or less is picked, some people can decide to have biopsy. Some can even go to as 10% of free PSA. If the value of free PSA is about 10%, some can call for biopsy right away. So now let me summarize here that when we get the ratio of free PSA to the total PSA, the more free PSA we pick, the better to say that we are not likely dealing with prostate cancer. The higher the level of the band PSA, that is the unfree PSA, the worse it is, that is, the more the likelihood that we are dealing with prostate cancer. So we don't want the band PSA, we want the free PSA. Okay? Now, let's consider another factor, that is the density. So before touching on density, let me quickly say something that the whole essence of serial PSA is to give us clue whether the cancer cells are dividing rapidly or not. Because when they are dividing rapidly, we will know through PSA values. Then we'll be able to tell that this is an aggressive cancer or not. Now, back to the PSA density. We need to have ultrasound done at this time, and we will go through the rectum, transrectal ultrasound, while we will be taking PSA in the blood. So, with the aid of that ultrasound, we can look at the size of the prostate gland itself. Then, when we tabulate the value of PSA acid through the blood, and we divide that by the volume of the prostate gland peak by the ultrasound, we will get the density. When the value is greater than 0.1, then we're in trouble. Some authorities will not even bother themselves about PSA density or not. Some will do something called the PSA and then the transition zone of the prostate gland will be taken. Okay, in that case, the part of the prostate that is making contact with the urethra, TH, that is the part that the ultrasound will assay as they want to pick the volume, okay, not the size of the entire prostate gland. So they use that as transition zone and then tabulate it as PSA then divided by the volume of the transition zone. So that is what some people will do. Majority will not even bother about all this, but for medical students and nursing students, it is okay for us to know that we can deal with all this. And then lastly, about serial PSA, because when you are doing serial PSA, what do you want to do with it? There's an entity known as statistical nomogram. In this case, we will use all the parameters available, like the free PSA level to the total PSA. We will consider, is this a black man, Asian man, white man? We will consider that. Then total history, any positive family history of prostatic cancer, how old are you? And then we will do so many other things like digital rectal examination, magnetic resonance imaging, CT, name it. We'll do everything that is expected to be done. And then we will now tabulate all this. The results, what we are able to pick, then will all be put in a statistical nomogram. And from there, prediction could be made that this guy will likely have prostate cancer. And with that, we'll be landing up on this, because statistical nomogram is helpful, but not many physicians will have time to do all this. So from the statistical nomogram, it is also easy to predict whether this is an aggressive prostate cancer or benign one, based on the rate of growth. So it's helpful, but remember, PSA alone cannot be uh, sufficient to make the prediction. So all other investigations will be put together and then make that prediction that we are dealing with this or not. Okay, my attention has been called into serial PSA, when to begin, and the disparity, as per referral. So that I should address when to refer again. Now, referral to the urologist will be necessary when PSA level of 4.0 nanogram per ml or greater is picked. But that is not fixed. Like I've said, and I'm going to repeat it here, everything about prostate cancer is not fixed. So we need those who really know about this seriously to handle it. Now, when I said 4.0 nanogram per ml, that is not fixed, because you can refer as low as 3 nanogram per ml depending on the age of this man. Then, if this is a young man and you are picking 3 nanogram per ml, refer right now. This is a black man with positive family history. You are picking 2.5 to 3 nanogram per ml. Even if not in the other races where it is very common, because like I said, prostate cancer is found all over the world. Okay? This is a white man, Asian man. Even in the Asian man where we expect lower value. At the point, the value of PSA will give us the signal to refer. Okay? Then we may not bother to refer if life expectancy is not on the side of this man. This might be 60 years, 50, but with other comorbidities, like lung cancer is somewhere already, the bad one, and or some other problem somewhere. And according to our books, this man is not expected to live longer than 5-10 years. There's no need to bother a urologist about it now, because there's nothing new he or she will do to ameliorate the condition. So, also, we will refer if this person has BPH on other reductase inhibitor like finasteride or dutasteride, where we don't expect the PSA to be rising, but unfortunately it's rising pretty fast. Like this year, the baseline is 1.5 nanogram per ml on finasteride or dutasteride with the history of BPH, and then the same man 12 months after, from 1.5 nanogram per ml is now 2.5 nanogram per ml or 3 nanogram per ml. Then I don't need any debate. I will pick the computer and make a referral. So, and finally on referral, we don't have to wait till we have serial PSA before we make referral. In some instances, if the baseline is high already, then referral is necessary today. You can see everything about prostate cancer is not fixed. Okay, Let's check phosphatase. In this case, prostatic acid phosphatase. We don't need to bother ourselves about this. The reason why I've decided to put it here is I have tagged this presentation prostatic cancer A to Z, meaning everything you can think of about prostatic cancer will be found here. So this is not good, as a yardstick to say you have prostatic cancer or not. But if you have the money and the time, you can assay it. If you assay it and you assay PSA, then that may give you a better clue. However, PAP, that is prostatic acid phosphatase, is less specific to prostate cancer, and it is less sensitive when determining whether or not you have prostate cancer. So we can summarize it or summarily say that it's not useful. And why that? Why the emphasis on not even thinking about this? It could be found in so many other cancerous conditions, even non-cancerous conditions, like any trouble or cancer, affecting the liver, the prostate gland itself, where we're going to find it mostly, but could be found in the testes, in lymph nodes, in red blood cells or leukemia, in bone marrow or the bone, and breast cancer, though not very commonly, and also in spleen and some other places that I have not mentioned. So, for the sake of medical students or nursing students, when you hear this, is a possibility, but it is not pathognomonic. Now, still on diagnosis, neither here nor there, right? We are still working. Let's see. Digital rectal examination. We go through the rectum, wear the glove, or put your gel or anesthesia or whatever. Then this cannot be used alone to determine whether we'll proceed to have biopsy or not. And we cannot say that, okay, I have done digital rectal examination, it is craggy and this and that, because of that, it is prostatic cancer. No, we cannot make a definitive diagnosis using DRE. You can not feel the entire prostate gland from here. You can only be dealing with the posterior part of the prostate. And at that point, we will not know what is happening at the anterior part of the prostate. So we can erroneously rule out prostate cancer because maybe the anterior part is the point where the cancer is, and we are feeling the posterior part of the prostate from the rectum. The ideal thing is we document that, okay, through DRE, I could feel that the posterior part of the prostate gland is so and so. Firm, rubbery, rough, craggy, hard, whatever. You are only feeling the posterior part of the prostate gland of that man. You don't know what is happening at the anterior part. If we say, okay, it is craggy, hard, oh, there is cancer of the prostate, without defining it to be posterior, and then we proceed to biopsy, well, whatever we find will determine what's next, but it is easier to rule out cancer of the prostate using digital rectal examination alone, and it might be erroneous. The findings can be added to other tests. Okay? So we are not saying digital rectal examination is out of place completely. No, that's not what I'm saying here. But you can use it alone. So have your PSA level, have your, transrectal ultrasound to look at the prostate, have your prostatic magnetic resonance image, determine whether you have the need for biopsy. Let the biopsy be done. Let's have the histology report. Then the grading is done by them, by the pathologist. Then we'll make a definitive diagnosis. So GRE is just a component, never alone. So if you've been to a doctor and the doctor says, okay, be in a recumbent position, DRE is done on you, and he removes his glove and he says, I'm sorry, you have prostate cancer. I don't know what to say. So I don't think anybody will do that. Okay, we are moving. Now, part of the investigations that could be done before arriving at definitive diagnosis will include magnetic resonance imaging. But in this case, you could see that I've added P. That is prostatic magnetic resonance imaging. Here we will use a contrast, and the name is gadolinium. With the help of that, we can see the soft tissues of the prostate gland itself. And that will help us with the help of multi-parametric magnetic resonance imaging to see the prostate gland and all other close organs around it, like testes, vas deferens, the bladder, the seminal vesicle, even the rectum. We'll be able to see that. Then we can also use this to guide the needle why biopsy is to be taken for the histology, okay? Histological studies, okay? Then, computer tomography, CT scan, that can reveal that there's metastasis to the pelvic structures or even distant metastasis. That can help. Then, positron emission tomography with the help of some tracers like sodium fluoride F18 and now then fluclovine or Pylarify or Posluma. All these could help to let us see, particularly with the help of prostate-specific membrane antigen, to see clearly the prostate gland and the cancerous nature of it. Bone scan. Bone scan will give us the clue that we are dealing with metastasis, and precisely metastasis to the bone. In this case, we will need not only the scan, but the biopsy of the bone so that we can unequivocally, I repeat to be precise, that it is actually the secondary from the prostate cancer, because it could be from the breast or any other paired organ, right? Here we don't need much, just a small quantity of radioactive agent is needed for this. It becomes necessary to establish this because bone is a very good place for prostatic cancer to run to, when they are spreading. I mean metastasis. The other friends that the prostate cancer would quickly run to once they are spreading will be the lymph nodes. Aside that, further away from the perineum will be the bone. Still on diagnosis, ultrasound. Don't say, what's the business of this man with ultrasound and prostate cancer? I have mentioned it times without number in the course of this presentation. Transrectal ultrasound will be helpful. Some call it endorectal ultrasound. Some will even be more precise and call it prostate sonogram. Whatever the nomenclature you gave to it, this is a very good tool when it comes to diagnosis of prostate cancer, though it is not definitive. It's very good because very fast enough you get it done. No, so you just go through the rectal. We will come to this when PSA is high, and we need to determine PSA density. Remember, the other time when I was talking about serial PSA, part of what we will do during the time we are taking serial PSA is to determine the density. Okay? If we have high index of suspicion for prostatic carcinoma, then we will call for transrectal ultrasound, otherwise known as prostate sonogram. This will be done before we have biopsy. Biopsy is always the last stage. And we can even use this ultrasound also to have biopsy done to guide, the needle. In this case, many will give prophylactic antibiotics, okay, and then with anesthesia. That is when you are using the ultrasound to have biopsy, okay. This transrectal ultrasonography is pretty helpful even in the treatment, like cryotherapy. You will know that maybe brachytherapy, because something must guide us to know where the pellets of the radioactive agent will be implanted. It can determine the PSA density of transition zone, like I've said, going through the urethra, of the prostate gland. So, transrectal ultrasound is pretty helpful here. Okay. The biopsy. How do we get here? Now that we're talking about biopsy, why? How did we arrive at the decision to have biopsy? Well, the PSA is high. Other results are pointing to the high probability of prostate cancer. Remember statistical nomogram that I refer to the other time? Then, if that decision has been made that the next thing is biopsy, the biopsy will be taken by the specialist urologist. It is called needle biopsy. Many samples will be taken, like 10 or even greater. Different samples from the same man, one prostate gland. But the samples will be taken from different parts of the prostate gland. That's it. And it could be taken through the perineal region. So we call that transperineal for transperineal biopsy. And that will be through the skin between the scrotum and anus. And it could also be taken through the rectal region. We call that transrectal for transrectal biopsy. That is through the rectum. Other equipment will be helpful here, like the ultrasound, transrectal ultrasound, magnetic resonance imaging, and sometimes we can combine both transrectal ultrasound with magnetic resonance imaging to guide the urologist appropriately to obtain the necessary samples. This is pretty good because we are now getting to making definitive diagnosis of prostate cancer. The biopsy is not without its own complications. There may be bloody ejaculation or blood stain seep. There might be hematuria, and pelvic region discomfort is a probability. Some people will have nausea and vomiting, and some will develop infection later on and even urosepsis. Inflammatory process can set in, affecting the prostate gland, known as prostatitis. And you could see from the structure I showed you at the beginning of this presentation, the epididymis will be pretty close. So epididymitis can also occur. Of course, there might be perineal or urethral pain, including pain in the entire pelvic region. Since transrectal region is also a possibility of the route to the prostate gland, there might be rectal bleeding as well. So this is how a biopsy will be taken, and then the samples will be sent to the histopathologist, who will then tell us if we are right or wrong as far the presence of the prostate cancer. Okay, the biopsy had been taken. Samples sent to the histopathologist. Then we might hear the news. It is biopsy positive or suspicious or biopsy negative. When it is biopsy positive, it means that cancer cells have been seen in the samples. When it is biopsy suspicious, it means it's not quite definitive, meaning we cannot rule it out and we are not saying definitively that it is cancerous. However, it is abnormal. That is biopsy suspicious. In this case, we can have what is known as, biopsy suspicious, we can have what is known as low-grade prostatic intraepithelial neoplasia, meaning the cancer cells are looking just like normal cells. So we are not quite sure, but we can go home and sleep. Still under biopsy suspicious, it might be high-grade prostatic intraepithelial neoplasia, or it might be proliferative inflammatory atrophy. In the case where we're going to pick redness, swelling, signs of inflammation. and at the same time, the cells will appear smaller than the normal cells. And it could be atypical small acinar proliferation or glandular atypia. Under the biopsy suspicious condition, we can go home to sleep. It might be biopsy negative. Does it mean we go home to sleep? Well, let me round up before you know. When it is biopsy negative, it means we are not picking cancer cells. No cancer cells have been seen in the samples. It might be false negative in the sense that the biopsy needle might have inadvertently omitted the real tumor site. I have told you, everything about prostate cancer is not fixed. So now the biopsy report is saying biopsy negative, and I'm now pointing it to you right now that inadvertently, not intentionally, the needle could have omitted the real tumor site, even with the ultrasound and magnetic resonance imaging assisted core needle biopsy procedure. If other tests are suggesting that we are likely dealing with prostatic cancer here, then we cannot go home to sleep. Meaning, when I said we cannot go home to sleep, I'm not saying for that very moment we won't sleep, but I meant that we are not closing the story here. So then we will do more things. Number one, we have to repeat this biopsy. Yes. We will have some other investigations done. So when it is negative, let's be sure it is truly negative. Let's do some other tests that we've not done. Even some tests that we've done but inconclusive, let's repeat them. In other words, for the first time of biopsy and the result comes back to be suspicious or negative, I will tag both as being inconclusive and we need to repeat biopsy. Yes. But when it is positive, then we move to the next stage, which is the report of the biopsy. Okay, here is a good bus stop to stop. For now. Let's examine adenocarcinoma, but I will be precise in bringing out the name as prostatic adenocarcinoma. And why that? Adenocarcinoma is not peculiar to the prostate gland. As a matter of fact, it is found in all glands, all organs that could secrete throughout the body. So adenocarcinoma is from the glandular epithelial cells of the prostate. Here, prostatic adenocarcinoma. That will account for about more than 90%. In fact, some authorities will put it at 95, others put it at 99. You can almost close your eyes and tell anyone who could walk to your office and tell you that you have been diagnosed with prostatic cancer, that, okay, you are likely having prostatic adenocarcinoma, because greater than 90% of prostatic cancer diagnosed will be adenocarcinoma, prostatic adenocarcinoma or adenocarcinoma of the prostate. This is the cancer that is found where the ducts and tubes are, the lining of it that is responsible for the fluid secreted by the prostate gland. There are two subtypes of adenocarcinoma, and I want us to get the facts about them very clearly. Remember, before now I've been telling you it is neither here nor there. You will get one of the many reasons why it is so right now. And the acinar subtype of adenocarcinoma of the prostate is the commonest of all prostate cancers. It means it is commoner than prostatic ductal adenocarcinoma of the prostate. Now, the acinar. Now, the acinar cells are all over the prostate gland and through all the secreting tubes and ducts. Okay, this will grow from the back, from the posterior parts of the prostate gland. Please get this right. And when you look at the diagram I have shown you earlier, you can see that posteriorly we have the large intestine, particularly the rectum. Okay, so it is pretty close to the rectum. So when acinar adenocarcinoma is growing and digital rectal examination is done, the physician is most likely going to pick it through DRE. You can feel it there. And this one, we also shoot up the PSA. So PSA is high, digital rectal examination is picking something craggy and hard, and you say, okay, yeah, that is prostatic carcinoma. You are close to it, but let's have biopsy done, right? Now, another reason is that you may not have only that, you might have, other types present as well, right? But in the case of prostatic ductal adenocarcinoma, something is different. It's less common compared to the acinar, right? But it is more dangerous. Well, it's good that it's not as common as the less dangerous one, okay? It can grow at the anterior or posterior or any part of the prostate gland. Unlike the acinar that is growing more at the posterior part. This one can grow anywhere, within the prostate gland. But something is about to drop right now. Are you waiting for that? Get it. Prostatic ductal adenocarcinoma may not give you high level of PSA. So, when I've said repeatedly, that if you don't have high level of PSA, don't tell the patient, or you, the patient, don't go and be pumping champagne. If you have prostatic ductal adenocarcinoma, your PSA may not be high, yet you have a very dangerous cancer, more dangerous than the acinar. Therefore, it is pretty easy to miss the diagnosis of prostatic ductal adenocarcinoma. Now, other types of prostatic cancer could be squamous cell carcinoma of the prostate sarcoma, transitional cell carcinoma. Remember, I have gone through transitional zone density the other time. When you get the prostate gland around the urethral zone, transitional zone. Okay. Then the other type could be neuroendocrine tumors, like small cell carcinoma. So it's good we have been able to look at this so that we will get the entire picture why diagnosing prostate cancer seems to be a little bit cumbersome. Now, the histopathologist will send a report in form of Gleason system. Now, when you find Gleason grade 1, that is pretty nice in the sense that it is pointing to the fact that the cancerous tissue is looking just like the prostate tissue. But when it is grade 5, that is pretty bad, meaning that the cancerous tissue is looking grossly abnormal. The cells are abnormal. The growth pattern, when compared to the normal prostate tissue, is grossly abnormal. Different parts of the prostate gland will have different grades when it becomes cancerous. The pathologist will consider two areas that appear the most. Okay? Then he or she will write down the best cause in each area and then add together. The score in each of the two chosen areas will be added together to form Gleason sum, like we have example there. Now, let me explain further what we get. Remember, the worst grade you can find in one area is 5. So, the highest Gleason sum anyone could get from two areas, even if the person is having two areas and they are both having the worst grade, will be 10, meaning 5 plus 5. When you look at the result and you find two figures, like one on the left and the other on the right, like 3 plus 5, giving you the Gleason sum of 8, take note of this. The 3 is the most appearing grade. Okay? So it doesn't mean the entire samples taken that is 3. No. It will be divided into two areas. The entire samples will be divided into two areas, right? I mean, of two areas will be taken, right? The commonest one in this case, in this example, is 3. And that is the most appearing grade. While 5 is the least appearing grade. So for this person, it's not a good news to have Gleason sum of 8, but when you compare the good and the evil, if 3 that is better is appearing most, which means Gleason grade 3 is appearing most and Gleason grade 5 is appearing least, then it is better than having the opposite. Because 8 is 3 plus 5, could be 5 plus 3. If the worst will be written first. Okay. The worst will be written first if this is appearing most and it is grade 5 that is appearing most, that is pretty bad. And if grade 3 is appearing less, that is not good. So someone with Gleason sum grade 8 and another person with Gleason sum grade 8 may not likely have the same prognosis. Let me repeat and I'll move on from here. Gleason sum grade 8 for two men may have two different prognoses. One has 3 written on the left, which means grade 3 is the most one appearing, while 5 is the least grade appearing. 5 is bad, but when we have most of the cells in grade 3, then the less, which is bad, that is A. B, the same grade 8, right? B, now let's look at B, the second man. The same Gleason sum, grade 8. If 5 is on the left, which means grade 5 is appearing most, and 3 is on the right, which means grade 3 is appearing less compared to the bad ones in grade 5, then the prognosis of this second man B is worse compared to the first man A, 3 and 5. So 3 and 5 is better than 5 and 3, because whatever you find on the left when it is Gleason system, whatever you find on the left means that is the grade that is the most common. Whatever you find on the right, that is the grade that is least common. Let's move on. Now, still on the system, Gleason 8 could be written in different ways. 3 plus 5 is equal to 8. Bracket Gleason 8. We are still Gleason 8. The same Gleason 8 could be written as Gleason 8, then you put bracket 3 plus 5, meaning grade 3, which is better compared to grade 5, is appearing most, while grade 5 is least, though very bad. So it is a better news for the man than the one with the reverse, 5 and 3. Then it could be reported as combined Gleason grade 8. I don't like this because you will not be able to tell precisely whether you are dealing with 3 plus 5 or 5 plus 3. Remember, I've said, and I'm repeating, 3 plus 5 is better compared to 5 plus 3, in the sense that 3 is a lesser grade, and it is the one appearing most. That is the one is reading first. 5 is the worst and is the least appearing. That is better than having the worst here appearing most and this less trouble on the right. And it could also be written as Gleason 8 over 10. Let me explain a little bit further here that 8 over 10 is saying the maximum we could get is 10. I mean, that is the worst that the Gleason could give us. That is the worst grade we can find. So out of the worst, the guy is having 8 over 10. That is not good at all. Also, like I've said, and I'm going to repeat and move on. Gleason 3 plus 5 is equal to 8. It is not the same as Gleason 5 plus 3. I won't waste time again because I've explained this over and over, but let me say it for the last time. The reason is that what is written first on the left, that is the one appearing the most. And in this first man, 3 is a lesser evil compared to 5, the worst grade. So if the most bad ones appearing will be 3, and 5 is less appearing compared to the 3, that is better for the man. Unlike the second man, that the most ones appearing will be the worst, number 5, and the least ones appearing will be the better one, 3. So the man with 5 plus 3 is worse compared to the man with 3 plus 5, though they both have Gleason 8. I hope you got it. Give me a thumbs up. Briefly, It is possible to have Gleason grade reported as similar, like 4 plus 4, 3 plus 3, 5 plus 5. In all, it means that we are dealing with the same pattern. So it will be reported like that, so that we have both sides compared. It's all the same. It's all the same grade. So more bad areas than good will be reported as we have explained earlier. And why that? So that appropriate actions could be taken by the physician. When the Gleason is increasing, it means that the chances of having cancer is increasing. But let me finally touch this, that the worst you can have is 5 plus 5, that is 10. When it is 7 over 10, like I've explained earlier, 7 is what the patient is having, 10 is the worst anyone could have. So having 10 out of 7, it means you are not yet 8, you are not yet 9, and you are not having the worst. You might come across sometimes under the biopsy and Gleason system as well differentiated. If you find that, that means it is of low grade. It is not aggressive. It is growing very slowly and likely going to spread slowly. So in this case, you are okay with watchful and waiting if the man is greater than 60 years. And in this case, you may find Gleason grade 3, 4. I mean, when you add both sides together, you're not going to get something so high. The maximum you can get there will be 6. That is well differentiated. Okay, and the Gleason grade will not be high, because once you reach 7, the story is changing. In the case of poorly differentiated, it means it is of high grade. When you get a report and it's written poorly differentiated, something bad is going on here. That is high grade, and this is expected to be aggressive. It is growing very fastly or rapidly, and it's going to spread in the same fashion. So Gleason 8 and above will be what we're likely going to pick here. The higher the number of Gleason, the worse the prognosis, you know that. So like I said, Gleason 3 plus 5 means that most of the tumor is grade 3, while less of the tumor is grade 5. So I'm repeating that here. Now, the moderately differentiated means that it is intermediate grade, right? And the Gleason score here will be 7. It can change for the worse from 7 to 8, 9, or 10. In this case, we will do something. We will do more tests, okay, to determine what the treatment pattern will be. Still on Gleason system, what I've been saying before now to so many people is pretty complex. Then the experts looked for a way to resolve that. So I tagged it as a solution to the complexity of Gleason system. So to get out of that, they embark on grouping into 6, 7, 8, 9, and 10. Okay, a new system of reporting is then out. Then, grade group 1 of prostatic cancer will be Gleason less than or equal to 6. So anything Gleason grade 1, 2, 3, 4, and 5, when you sum everything together, up to 6 is grade group 1, prostatic carcinoma. Grade group 2 will be Gleason 3 plus 4, which is equal to 7. You can now see this. While grade group 3 will be Gleason grade 4 plus 3, which is equal to 7. You can see that there's difference between 3 plus 4 and 4 plus 3, and they are still the same 7. So, because you will agree that grade 2 is less of evil compared to grade 3. Just like what I've said, the worst one is on the left, the less evil is on the right. If the number has switched here from the good ones being the worst one being less compared to higher number of good ones, here the bad ones are more than the good ones. So that is why this one is carrying a worse prognosis compared to grade 2. Why grade group 4 will be Gleason 8. Either 3 plus 5 or 5 plus 3. 8 is always bad, when you compare that to 7. And of course, grade group 5 of prostatic carcinoma will be anything 9 and 10. I'm not sure, but my assumption is that they have agreed to put 9 to 10 together because what is the difference between 9 and 10 anyways? Someone at grade 9 is as bad as grade 10. Okay, here's the question. Is Gleason system magical? Meaning, is it solving a problem? When it comes to prostatic cancer prognosis, even the Gleason system is non-magical. Definitely no. And why that? I have said it, and I'm going to repeat it. Everything about prostate cancer is all over the map. So we'll look for it all over the place. So what is happening? Why is this not the end of the road? Why can't we rely on this completely? We can inadvertently miss the very spot where the aggressive tumor is. Like we said, on the left, the worst ones, on the right, the good ones. You write 3 plus 5, you sum that to be 8. But what if we have missed the spot that is, harboring the worst cells? Human error in reporting is what we should give room for, right? So it might be. Some believe that in 20% of cases, the cancer is worse than Gleason report would have given us through biopsy. Then, if that is not the last about how to make the definitive diagnosis, then what is the way out? Okay, we should use Gleason as one of the many tools to make final diagnosis. That's it. We will add the results of other investigations, measures. Then we will put that with what the Gleason report through biopsy is telling us. Then we can diagnose prostatic cancer definitively. Isn't this a big job? Herculean task, right? It is. So finally, we can say that we can make definitive diagnosis of prostatic cancer and go home to sleep, figuratively, if the biopsy is done, Gleason system report and grading is here. We have what the bone scan is saying. The ultrasound is telling us something. Digital rectal examination has pointed to something. We have other tests that could help us by comorbidities already establishing that or ruling them out. We have the PSA, we have the prostate acid phosphatase, we have the X-ray, we have the bone scan, name it. We put all together and then tell the patient, this is the diagnosis. Okay, TNM classification of prostatic carcinoma. T is all about the tissue, that the tumor is too small to be seen through the ultrasound or palpation. T1 has T1A, T1B, T1C. When it is less than 5% of the removed tissue, it is T1A. When it is equal to 5%, it is T1B. When it is found through biopsy after PSA has been raised, it is T1C. Now, T2 is all about the fact that the tumor is inside the prostate gland completely, while T3 is telling us that the tumor has penetrated through the capsule of the prostate gland. That is T3. T3A saying the same thing, penetrating through the capsule, covering the prostate gland, while T3B is telling us that it has spread into the tubes that are carrying the same. Now, T4 means that the tumor has spread to the neighboring organs. The bladder is suffering now, pelvic wall affected, then rectum affected. The neighbors are suffering. While the N here will be the clue about the lymph node involvement, whether it has spread to the lymph nodes or not. We have NO, means the nearby lymph nodes do not contain the cancerous cells from the prostate gland. While N1 means there are cancerous cells in the lymph nodes around the prostate gland. Now, M is all about metastasis or not, whether we are dealing with distant metastasis or not. So MO means there is no distant metastasis. M1 means it has metastasized beyond the pelvic region. In that case, we want to find out, is it M1A, M1B, or M1C, where M1A means it is found in the lymph nodes outside the pelvic region, while M1B means the cancer cells are already found in the bone, while M1C means it has gone far away from the pelvic region and is now far, in the torso, the chest region, found in the lungs and even above. There are other tests that we can do to support the health status of this man. Let's have complete blood count done. There might be even having leukemia, we don't know. Let's have the urinalysis done. Maybe that will point to having, random blood sugar or fasting blood sugar done when we pick a level of glucose. And then maybe that will be the first time he will know that he has diabetes mellitus. Let's have nitrite. Though that may not be definitive as per knowing whether there is urinary tract infection or not, but that will set us on motion to do more. Some will even have procalcitonin done. Urine microscopy culture and sensitivity, just to be sure it is not urinary tract infection. We can have blood culture, blood NCS. We can have electrolytes done so that we will know that before subjecting this man to so and so pattern of treatment, he or she has the body that could take it. Because when we pick other comorbidities, then that, in fact, me and taking the blood pressure can point to hypertension. And who knows if it's going to be, hypertensive urgency. Might even be hypertensive emergency. So we want to rule all other disease conditions out before making up our mind whether or not this man will take so and so pattern of treatment in addition to the age or not. So don't let me waste your time. Let's move straight to the treatment of prostate cancer. Now, treatment. The first part of treatment is you do nothing. You carry on with surveillance. You wait patiently and be watchful. These will be applicable if we're dealing with older men, or there are other associated terrible comorbidities that would have reduced the lifespan or expectancy to nothing more than 10 years. Or it is a small cancer that is limited to the prostate gland alone. And also, it is not growing aggressively. Even if it is growing aggressively, but the life expectancy is less than 10 years, will do nothing. There will be no serious symptoms here that will be associated that will warrant intervention. Because if we find that, except that if the man is so old enough and close to the grave, then we'll still have to do something. Okay, when it comes to watchful waiting, what we'll do is frequent follow-ups. We'll continue to monitor the signs of symptoms. And then we'll be taking blood sample for prostate-specific antigen. Many other tests we may not do. We may not have to bother the life of the person so much. The active surveillance will take the following pattern. We will be monitoring this man very closely with PSA every 6 months. We will do digital rectal examination every year. Biopsy could be done every 1 to 3 years. Then we will do other investigations like magnetic resonance imaging, CT, PET, as it deems fit. So we want to just leave the person like that. The group where we will be doing surveillance will be younger age group with small gland that is not growing aggressively. Let me take that again before we leave this page. Surveillance would be appropriate in an individual with life expectancy greater than 10. The tumor is not aggressively growing, it is slowly growing and is limited to the prostate gland. In that case, because it's not necessary to subject an elderly man with life expectancy less than 10 years with other comorbidities to the rigor of PSA every 6 months, digital rectal examination every year, biopsy every 1 to 3 years, doing MRIs. They are not necessary. The surveillance is necessary. When this man has more than 10 years life expectancy, still young, maybe 60 years, 45, 50, but the tumor is still small. It's not aggressively growing. and the symptom is not getting worse. So we'll continue with surveillance. Okay, let's examine brachytherapy. Here, we'll be dealing with radiotherapy. It has other names. Some call it seed implantation. Some call it interstitial radiation. Here, we're going to use small radioactive seeds called pellets. They are very tiny, like grain of rice, right? These pellets will be implanted into the prostate gland that is cancerous. You know that we can't do that with naked eyes, right? We use ultrasound and MRI. Sometimes some people will combine both. It may be adopted if the cancer is non-aggressive and we have picked the cancer at the early stage of it. Fine, we'll go for that. We may not use brachytherapy alone. It is possible we combine this with other forms of treatment. We don't use brachytherapy when we are dealing with numerous foci of the cancer cells, in prostate gland. We can use this under general anesthesia. And some people will opt for the regional anesthesia like spinal anesthesia. So it may be for a short period of time, temporary brachytherapy. If we are going for the option of temporary brachytherapy, the individual will be given high dose of the radiation. So the radioactive pellets will be that of the high dose for a short time, like few minutes, 15 minutes, and that will be one treatment. It is possible you give more than 2 of such over 2 days. Okay. We must be very precise on what we are going for. High dose for 15 minutes, and you repeat that for 2 days and you stop that cycle. Then permanent brachytherapy, we are going to use low dose radiation. The seeds here will be like iodine 125 or palladium 103. Will be implanted inside the prostate, right? And it will remain there and be releasing low dose of radiation, for weeks and months. Unlike the temporary that we're going to go give for 15 minutes and then you do that 2 days in a week. Since the radiation will not be going far, we are sure that damages to closed structures is going to be minimal. However, we'll still be dealing with some side effects. It is possible that the seeds or other names is pellets, of the radiating particle could radiate to the people around you. So you are a man, you're on brachytherapy. The type you have chosen is the permanent brachytherapy, is already implanted in you, and then you are home, your wife is pregnant. Be careful, she might take some doses from you. Okay? Or you have a little child and you are the same person helping to cuddle the child, to change the diaper or everything like that. Be careful, you might be passing the radiation to the little child. You may excrete or ejaculate some of the seeds. So that is why if you have to still relate with your wife, I'm not going deeper more than that, you use protection, condom. Inflammation of the rectum is a possibility, so proctitis, okay? Because we'll likely go through that means. Urinary incontinence is a possibility with irritative symptoms, right? Then, because we'll go through the urethra sometimes and then get it implanted, there might be urethral stricture leading to obstructive uropathy. And of course, all our interventions will likely end up with erectile dysfunction. Another form of intervention is the use of radiopharmaceuticals. Example of such would be Pluvicto. So in this case, the radiopharmaceuticals will be targeting prostate-specific membrane antigen. These PSMA will be found in large amounts on the prostate cancer cells. So when you grab your Pluvicto, you inject intravenously. That will reach PSMA in the prostate gland. Then it will release the radioactive agent there, killing the cancer cells right there. It is pretty successful on its own many times, but it will be better or advisable to shrink the tumor with chemotherapy before giving radiopharmaceuticals. PSMA PET scan is necessary before the onset of the use of radiopharmaceuticals. With that, we need to be sure that the target cells are in the system, because if prostate-specific membrane antigens are not there, radiopharmaceuticals will just become poison. Yes, that is the right word. Because if we don't have PSMA and we give radiopharmaceuticals, those are the target cells, and they are not there, then it's going to start working to target any cells it could find. And that is toxicity, which is a form of poison. But if that is not the case, if the target cells are there, then the side effects will reduce. So PSMA PET scan will help to say, oh, the PSMA is right here. So go and grab that radiopharmaceuticals, inject it, and that will work. So that is the best way to go about radiopharmaceuticals. Okay, external beam radiation therapy, we won't waste time on that because we're all familiar with X-ray, right? So externally delivered. In this case, it is going to be useful for early stage of prostate cancer when our target is to cure, and also pretty useful for the very, very bad stage of the cancer that has metastasized to other parts of the body. So either early or terribly late, aggressively spreading external beam radiation therapy could be helpful. Here, we are going to use higher doses of radiation, and then we'll be targeting the tumor directly, okay? Then we will have to employ services of three-dimensional conformal radiation therapy. This one can locate the tumor on the prostate gland itself and deliver the radiation to the specific site. Isn't that great? Then also it is helpful if we can make use of intensity modulated radiation therapy. That is an improved version of the three-dimensional conformal radiation therapy in the sense that it is the most used of external beam radiation therapy for prostatic carcinoma. Here is going to make use of image guided radiation therapy with the capability of precise delivery of the radiation in several angles to the prostate gland. And here, since we are making use of image-guided radiation therapy, the image will let you deliver directly to the prostate gland. So collateral damage to the neighbors, the closed structures, is appreciably reduced. Then you can move further a bit that you can use volumetric modulated arc therapy. The arc there means it's going to rotate around the body and the radiation will be delivered. So intensity modulated radiation therapy takes weeks to be delivered. Then we can also have stereotactic body radiation therapy. Here, we are going to use large dose with a precise location. This will take several days to be completed. And finally, we can have MRI guided radiation therapy. That would be awesome, right? There's nothing good without side effects. Radiation is not good, but in someone with cancer, well, you are just looking for a way out to, lead a good life before, whatever will follow. Yeah. There may be inflammation of the rectum. Then sometimes bowel incontinence, urinary incontinence can happen, rectal stricture, rectal leakage. In fact, there may be impotency, and some call it erectile dysfunction. There is likelihood of trouble with the bladder, with radiation cystitis. There may be diarrhea, the fatigue, or lymphedema. All this could occur when anyone is on radiation. Now, the big topic, hormonal therapy. By way of introduction, testosterone is an androgen produced in the testes, adrenal gland, and prostate gland, but mostly produced in the testes. This testosterone is the strongest ally to the prostate gland when it comes to its survival. Testosterone helps the prostate gland to grow. So, the intelligent ones, the experts, decided that there's a way to punish the aberrant prostate gland that is now producing cancerous cells and is growing abnormally, trying to kill this one. So they concluded that we're going to cut off the food supply to this stubborn organ. And they've decided, let's do something. Let's cut off the androgen. That is why some call it androgen deprivation therapy, meaning testosterone deprivation therapy. This can stop the formation of prostate gland cells. It can prevent it from reaching, it can prevent testosterone from reaching the prostate gland, and that can later kill the cancer cells by way of starvation. If the cells still find ways to grow through another means, it's going to be pretty very slowly. Like I said, some will give it another name, androgen deprivation therapy. But remember the adrenal gland. Remember hypothalamic pituitary adrenal axis. When the hypothalamus is releasing and controlling what the pituitary gland is producing, sending signal to adrenal gland to produce the hormones there. The same way, we will remember hypothalamic pituitary gonadal axis, where the hypothalamus will be sending signal to the pituitary, who in turn will send signal to the testes, where testosterone is produced in lady cells. We use this. But let me move to the next slide. Yeah, we've understood what hormonal therapy is all about. We can use it alone or in combination with other methods of treatment. When metastases has occurred, hormonal therapy will still be pretty helpful. Wherever the prostate cancer cells are located, when we deprive it of testosterone supply, it's going to solve it there. We can also use this when the plan is to have radiotherapy with external beam radiation therapy. We can use this 3 months before we will use the EBRT. What we want is the prostate to shrink in size. And it will be better in locally advanced prostate cancer when we have used the hormone therapy preceding the use of the external beam radiation therapy. Then it would have reduced in size. We want it to shrink so that the radiotherapy will be able to hit it better. So I've gone through the uses together, right? So there are 3 ways to do this. We can do this castration, because when testosterone is cut off, we are castrating it, okay? So we can do this castration surgically by removing the testicles. In North America, they call it testicles. In Europe, they call it testes. So either way, we get it off, or get them both off. Then we tag that as ocheectomy. Okay? It is hormonal therapy because we are removing our aim is to remove the source of androgen, testosterone. So surgically done, ocheectomy. If that is not the option, then we can have anti-androgen pills. Or the third option is luteinizing hormone releasing hormone, LHRH. Don't worry, I'll go into details of each of these very soon. As a matter of fact, when we are using LHRH antagonist, we will still need anti-androgen pills in the face of flare. So that is how hormonal therapy will work. Let's see other things. Okay, luteinizing hormone releasing hormone. Remember, I have said hypothalamic pituitary adrenal axis and hypothalamic pituitary gonadal axis. The LHRH will be sent into the circulatory system by the hypothalamus. Okay? Then that will act on the pituitary gland, anterior pituitary, to release luteinizing hormone. That is hypothalamic pituitary, right? Now, hypothalamic pituitary gonadal axis. The luteinizing hormone from the pituitary will act on the testes or the testicles, specifically the Leydig cells, to start producing testosterone. Remember, I decided to use hypothalamic pituitary adrenal axis also because the adrenal gland is capable of producing sex hormones, the androgen, from the adrenal cortex. So the impulse from the hypothalamus to pituitary to the gonads or adrenal axis will be cut off when we adopt luteinizing hormone releasing hormone as a form of treatment. Now, there are two ways. Either we use luteinizing hormone releasing hormone agonist or antagonist. Let's consider the use of the agonist first. This will block pituitary gland from producing luteinizing hormone. Luteinizing hormone releasing hormone is also called gonadotropin releasing hormone. It will initially stimulate the luteinizing hormone production, and then that in turn will work on the testicles or testes to produce more testosterone initially, and that is called the flare. Okay, the persistent presence of luteinizing hormone releasing hormone agonist will cause a form of fatigue as per luteinizing hormone production, and subsequently cut off the testicular capability of androgen production. That is, cut off the power to produce testosterone. The use of LHRH here is called medical castration or chemical castration. Remember, I said chemical castration or surgical castration. Surgical castration is orchiectomy. This is medical. The agonist here, example would be leuprolide, goserelin, or triptorelin, will be administered in form of injection or implant every 1 to 3 months. The flare here, which will be the overproduction, sudden acute overproduction of testosterone, will lead to obstructive uropathy, spinal cord compression, or bone pain. So that is what we do with the agonist. Now the antagonist. Here, luteinizing hormone releasing hormone antagonist is also called gonadotropin releasing hormone antagonist. This will work differently in the sense that what they will do is to block the site of LHRH on the pituitary gland. So when that is blocked, it's going to prevent the production of LH. And when LH is not in the circulatory system, there's nothing reaching the gonad to stimulate the production of the testosterone, thereby halting or stopping the production of testosterone from the testicles. Good news here is that we don't have flare when it comes to the LHRH antagonist. We have two examples. The first one I'm going to talk about is the degaredis. That one is the injectable form. We also have relugolix. That is the one we can give per oral. Those are the two LHRH antagonists. Remember, Leydig cells in the testes or testicles will be responsible for the production of testosterone, while the Sertoli cells will be responsible for the spermatozoon production. And adrenal cortex has the capability of producing aldosterone, cortisol, so the glucocorticoid, the androgens, and estrogens. So that is how we use LHRH. Still on hormonal therapy, let's have a look at anti-androgen pills. Here we have example like flutamine, nilutamine, apalutamine, darolutamine, or enzalutamine. The commonest one with the brand name Calcidex is what many people will be familiar with when it comes to prostatic cancer. Okay. Another anti-androgen is spironolactone. That is used as diuretics in treatment of acne or vulgaris and so on. And sapropterin is used in polycystic ovarian syndrome in women. We are out of all those right now. So let's be back to example like Calcidex. In total androgen blockage, we will do something different. We will use these anti-androgen pills that will be given per oral, and we'll combine that with ocheectomy. That is surgical castration. We're going to remove the testicles. Or we'll combine that with luteinizing hormone, releasing hormone. Most of the times when it comes to prostatic carcinoma, we will use LHRH and use anti-androgen pills to tackle the flare. Now that is the surge of testosterone, following the administration of LHRH before the full effects will set. What the Calcidex will do here, the anti-androgen pill will do here, is to block the androgen receptor cells where the testosterone is expected to bind. They will go there to competitively bind to the same site. So even if the testosterone is available, it's going to be useless because the binding sites would have been occupied by Calcidex, the anti-androgen pill. So the cancer cells will not be able to make use of the testosterone and then be starved to death. After the use of LHRH or surgery with ocheectomy, we don't fool ourselves to think that testosterone production is completely halted. No. Because there is that likelihood that adrenal glands and some surviving parts of the prostate gland can still be producing testosterone. So we will still continue to use Calcidex to block the effect of the extra testicular production of testosterone. So all we want is starve the stubborn prostatic cancerous cells to death by cutting off the only food they like, which is testosterone. Now, ocheectomy. This is the surgical castration. It is irreversible. And here, like I've said repeatedly, you are removing the testicles. That is the source of testosterone chiefly. But that is not the only source of testosterone. But majorly, it is from the testes, hypothalamic pituitary gonadal axis. It is irreversible, like I said, so it is permanent. The need for other treatment modalities is also applicable here, because even when you have removed the testicles, you might have the need again to remove the cancerous prostate gland itself. Then you can embark on radiation or radiotherapy. Your surgeon may choose to have incomplete removal of the entire testicle, and that will be subcapsular ocheectomy, where the inner part of the testicle alone is removed. You might join the women the postmenopausal women will be battling with hot flashes. And then infertility can set in, or with erectile dysfunction. That is why it is advisable to have that robust conversation before you sign the contract to have this done. Most of the people that will choose this option will rather choose this option because they have metastatic adenocarcinoma of the prostate. And then they will have this as one procedure done and for all, while others will still choose estrogen in place of this. It could be done using general anesthesia if you choose, or the regional anesthesia as your choice may be, after proper explanation. One other side effects besides infertility, erectile dysfunction, and hot flashes would likely be that you have anxiety and depression, because permanently this is done. All you can have is processes, if you want, I don't have to go into that, so let me skip. So that is what orchiectomy is all about. When it comes to castration and prostatic cancer, for the sake of those who will need this for paperwork, or for medical students or nursing students, it's all about what I've said about hormonal therapy before now, but I can cap it off all within a few minutes. Androgen deprivation therapy, either orchiectomy or luteinizing hormone, releasing hormone, or anti-androgen pills, will all be what we are going to adopt here. But in addition to that, we'll do some other things more when we just don't want that prostate to get testosterone by all possible means. Remember, hypothalamic gonadal axis as far as hypothalamus and luteinizing hormone, releasing hormone, and then pituitary with luteinizing hormone, and then the gonad, that is the testes or testicles, the lady cells producing testosterone. Remember, hypothalamic pituitary adrenal axis as hypothalamus, pituitary, and adrenal gland producing testosterone. Now, the hypothalamus releases LHRH that will act on anterior pituitary that produces and releases luteinizing hormone. The luteinizing hormone will act on the target cells, here lady cells in the testicles or testes. Lady cells will then produce testosterone, which is the androgen. Remember, we're dealing with androgen deprivation, right? Okay. Then the androgen fills the prostate gland, making it fat, deprivation of which is termed castration. It could be chemical, like we're given this medication, or surgical, when we have orchiectomy. Also, hypothalamic pituitary adrenal axis can produce testosterone. And the anti-androgen pills will be in two generations. The first generation will be glutamine, beta-glutamine, nilutamine, and so on. But the second generation will be enzalutamine, apalutamine, darolutamine. They are better than the first generation. And someone will ask me, how come that they're better? Adrenal glands and the prostate gland can still continue to produce testosterone. This is where I'm going. That's why I'm bringing this out separately. Can still continue to produce testosterone even in the presence of those anti-androgens. Then we look for something different again to block the synthesis of testosterone completely. Okay? The extra testicular production of testosterone is in small quantity because the highest production of testosterone is right inside the testicles, precisely in lady cells. But the small amount that will come from outside the gonad could do enough damage. Could be powerful enough to enhance the growth of the cancerous cells. So, what are we going to do? From cholesterol, an enzyme called Cytochrome P17 helps in testosterone production, in the testicles, from hypothalamic pituitary gonadal axis and adrenal gland, and then also from the prostate gland tumors. That CYP17 enzyme will be targeted by a particular set of medications: abiraterone, ketoconazole, and aminoglutamide. Remember, the sound of ketoconazole should give you a clue that this medication is also useful for something else, right? I know you know, like for fungal infection. But ketoconazole is not only useful for fungal infection, so it's for fungal infection, could work as anti-androgen and could work as anti-glucocorticoid. No, so metastatic prostate cancer cells, are castration sensitive, while some of those prostate cancer cells are castration resistant. Meaning, you will do all that I've said before this very slide, yet you will not be able to get rid of them. Those are the castration resistant. Then we can use combination of medications. Either we want to deal with castration sensitive so badly that it will be completely castrated, or we are envisaging that it could be castration resistant. So we will combine strong medications from the onset to deal with it seriously. In that case, we can go for the following combinations: abiraterone with prednisone for metastatic prostatic cancer cells, abiraterone with enzalutamide, that is second generation antiandrogen with abiraterone, ketoconazole with glutathione. Remember that glutathione is an hypnotic sedative agent, okay, meant for some other conditions, but useful as second-line agent in castration-resistant prostate cancer cells. So even when we have done everything and it's like we're not winning with the hormonal therapy, we can still calm down and grab ketoconazole with glutathione, or grab abiraterone with enzalutamide. So abiraterone with prednisone, all will help in castration-resistant and prostatic cancer cells. The side effects of hormonal therapy: gynecomastia from anti-androgen pills, stress, from daily intake of anti-androgen pills and estrogen. Remember, estrogen can give DVT that will go on to become pulmonary embolism, heart attack, stroke, and partial stroke. All the interventions can lead to erectile dysfunction. Flare can occur at the early parts of the use of LHRH agonist. LHRH must be taken every 1 to 3 months. For some people, that is straight, right? When you are selecting, remember, when you choose osteotomy, that is surgery, it is irreversible. Osteoporosis can set, bone mineral density can drop, and easily you can fracture your bone. Hot flashes can be occurring just as your wife that is above 50 years will be having it, then you'll be having it also. And that is a troublesome condition, right? You may become unnecessarily tired, and there may be increased muscle loss. You might have memory fog, and you can have depression with increase in weight. The penis size might reduce. There may be loss of hair. And when you're on steroid for too long a period of time, you can come down with type 2 diabetes mellitus. Anti-androgen pills can also cause hepatitis. So, something different will happen. And that is called intermittent dosing. So let's get to the next slide. Okay, someone is about to choose hormonal therapy, but you are afraid of the side effects that I've just gone through. There's another way out. You can have what is known as intermittent dosing. Okay, here, you are going to take that hormone therapy and you'll be followed up with PSA level. Now they'll be calling you to have PSA level acid. When PSA, that is prostate specific antigen level, drops, and it drops very, very low, you'll be instructed to stop taking the pills. When you have stopped, you'll be, because it is reversible. Once it is not, the surgical procedure, it is reversible. So you will continue to regain everything you've lost, but we'll continue to monitor the PSA level. When the PSA level starts rising again, then you're going to start taking the pills again. In that case, before the side effects will set in or become horrible or unbearable for you, it's likely that the PSA level will have dropped to a point that will ask you to stop again. So you'll be able to decrease the side effects and enjoy more of your life. Chemotherapy. Because this presentation is pretty long right now, I will just be touching on the key points from this point and forward. Chemo is not curative, meaning there's no assurance that when you use chemotherapy, it's going to cure the prostatic cancer. We can use chemo under the following conditions. One, when the surgery has been carried out, we can use chemo for a short time. Some use chemo to shrink the cancer before surgery. We can also use chemo with hormone therapy. It is advisable to use hormone therapy first, but we can also use chemo when hormone therapy has failed. We use chemo in advanced prostatic cancer, not in early prostatic cancer. We don't go for chemo as the first modality of treatment when the cancer is still early. But in advanced case, yes. When it has metastasized, yes, we go for chemo. Examples of chemo that we can use would be docetaxel, cabazitaxel, mitoxantrone, extramuscin. We can also choose from the platinum-based chemo agent like carboplatin, oxaliplatin, and cisplatin. Docetaxel is the first drug of choice when it is all about prostatic carcinoma. We give this agent, that is docetaxel, with prednisone. I will explain why in a bit. The second that we can go for if we are not winning with docetaxel will be cabazitaxel. Now, the chemo will be given in cycles. You'll be given the time to rest. Then your doctor will tell you when you come back for the other cycle. Tell your physician any medication you are taking before the decision to have chemo will be made. Now, metastatic hormone-sensitive prostate cancer is another interesting one to consider. The first attempt here will be hormonal therapy with anti-androgen. Then you can opt for bilateral oophorectomy. All we want is to decrease testosterone. Most men will avoid surgery and would rather have medication. If that is the case, we can choose both chemotherapy with some of these anti-androgens. As a matter of fact, some will opt for chemotherapy and radiation. So those who will choose only pills, we can have triple therapy. That is anti-androgen. We'll give that with docetaxel, and we'll give that also with abiraterone. Remember the castration resistant stuff, right? So triple therapy, anti-androgen, docetaxel, abiraterone. You can also use drolutamide or enzalutamide when you are making your selection. Some will go for double therapy, not triple, like enzalutamide, with abiraterone. Okay. Docetaxel is given with prednisone. Abiraterone is also given with prednisone. So why prednisone here? This is just to add like a spoiler by sending a negative feedback to the hypothalamus that will in turn lead to the reduction in the production of testosterone. Remember hypothalamic pituitary gonadal axis and hypothalamic pituitary adrenal axis, right? When the adrenal gland or the gonad is receiving the impulse from the pituitary is receiving from the hypothalamus, and that is cut off somehow, then we are not going to get more production of testosterone. So prednisone here will block hypothalamic pituitary adrenal axis. So adrenal gland secretion of testosterone will be cut off. Okay. The prednisone will also help as an anti-inflammatory agent or anti-allergy. Remember, I will soon go through the side effects of this chemo right now, and let's quickly brush that. There could be nausea, vomiting, diarrhea. Some will have constipation. Okay, the white blood cells can drop, and that will lead to increase in infection from decreased immunity. Some will have bleeding and could manifest as bruising. There may be fatigue, loss of appetite. We all know that there will be hair loss, right? Mouth sores, and in fact, chemo fog in the brain. Some will have severe allergic reaction, even peripheral neuropathy with docetaxel and cabazitaxel. So you can see why prednisone will be pretty helpful. Besides blocking the hypothalamic pituitary adrenal axis, is going to serve as anti-allergy at the same time. Chemo can also cause cancer on its own if you are named for a long time, like you are named for years. For example, leukemia. Leukemia can follow mitoxantrone use for a long time. There is that likelihood of increased blood clots when you are on extramustine. So with that, I'll come to the end of chemotherapy. Let's move on. Cryotherapy. This is not commonly used, but for academic purpose, we can have a review of it along. So we all understand that cryosurgery is just about using very cold air or cold fluid anywhere to freeze unwanted tissue. right? Some call it cryoablation also. But this will be employed here when prostate cancer re-emerges, okay? When you've treated and it's now repeating itself, it's reoccurring. Then you try something new, right? Okay. Never the first choice for treatment of prostate cancer. I'm going to repeat that. But it's pretty useful when we are dealing with early prostate cancer. And the prostate cancer is low grade. And it is also useful when this man cannot have radical prostatectomy. And this man can take radiotherapy. You say that instead of looking at the man, no, doing nothing, then we'll go for this, right? So there's no harm in that. You might be given general anesthesia or regional anesthesia with spinal or epidural. Then we'll go through transrectal ultrasonography to pass the cold gases, okay? The concern is what will happen to the urethra. That could be protected, from the severe cold by passing warm and salty water. So that is one way to get that done. The type of patient to be selected for this, besides what I've listed earlier, will be someone with small prostate gland, even with the cancer in it, okay? Because it's not going to help a man with large prostate gland. When you are thinking of whether to have cryotherapy before radiotherapy or radiotherapy before cryotherapy, it is better to have it before you have radiation, okay? Now, what are the possible side effects? There might be hematuria. The individual can be, bleeding. Definitely, erectile dysfunction. Fistula may occur between the rectum and the bladder. Then some come down with urinary incontinence, then swelling in the perineal region. There might be pain everywhere. So that is that about cryotherapy. Not many people will even try this, but when we can't make use of the rest, then we'll settle down, to have cryotherapy. Surgery. Here is all about prostatectomy. This is the way to excise, or we call it prostate excision. Okay, this is the surgery to remove part or all of the prostate gland. It might be simple or radical. I will explain further in a bit. You can have robotic assisted form, and you can have open surgery or laparoscopic surgery. Now, let's check the simple prostatectomy first. Simple prostatectomy is mostly indicated when we are dealing with benign prostatic hyperplasia, when the affected individual can no longer cope with the obstructive uropathy. This is a minimally invasive procedure. We can use robot-assisted technique, but no open surgery. No open surgery. That is simple prostatectomy. The segment of the prostate gland is removed. Not the entire prostate gland will be removed. No. And when that is the case, we'll say that is simple. This will be as a result of obstructive uropathy with impaired storage of urine, leading to urinary frequency, urinary urgency, nocturia, or with impaired voiding no, unable to void completely, and are battling with difficulty initiating the menstruation. Some were poor stream and intermittent, urine stream. Then some will have dribbling after the voiding. Some were very slow and prolonged urination. Um, they will have a feeling of incomplete empty. And the storage of the urine would have led to urinary tract infection. Then some will be down with oliguria, and complete absorption can even lead to anuria. Hematuria adrenephrosis may occur here, and some will develop bladder stone. So when that is the case with benign prostatic hyperplasia, you call for simple prostatectomy. The second part of prostatectomy, or the second example, would be radical prostatectomy. In this case, unlike the simple, the entire prostate gland is removed. Lymph nodes surrounding it will be excised, will be removed for histopathological studies. You can use either robot-assisted means, that robot-assisted radical prostatectomy, or open radical prostatectomy, open surgery. Then you can ask me, what are the possible indications for this massive excision of many structures in the pelvic region? Number one, when the entire prostate gland is suspected to be removed, then it will be radical prostatectomy. If the cancer has not metastasized to distant organs, then surgery is reasonable. When it has metastasized to distant organs, there is no need torturing this man with either simple or radical prostatectomy. No more, no need. When the surrounding structures like seminal vesicles, vas deferens will also be removed, then it's going to be radical. Now, when oliguria or anuria has stepped in, meaning there is severe uropathy, then radical prostatectomy might be the expected intervention. We are battling with hematuria. In fact, nephrolithiasis due to the prostatic cancer, blocking the flow of urine, then accumulation of the element therein. So, stone in the bladder, stone in the kidney, slow urination, hydronephrosis. The other issue will be when we table every means of treatment and the patient chooses to have radical prostatectomy, then we can go for it. And also when the patient cannot take hormonal therapy, cannot take chemotherapy, cannot take radiotherapy, then what do we have left? And the life expectancy is still, more than 10 years. Then we'll help him out with radical prostatectomy. So the other issue is the approach to radical prostatectomy. It can be through retropubic approach, where you make small incision or in the incision, and that is better, particularly in younger age group, because it is going to give better cosmetic effect. Yeah, and major muscles are bypassed. There will be less pain, and recovery will be faster than using the perineal route. Another type will be nerve-sparing prostatectomy. In this case, you want to do everything to preserve the erectile function. This will be helpful if the man is still young and maybe, now you understand, I don't need to go into detail. So you just do everything to bypass the uh, neurovascular bundle. Now that will be by the sides, two of them on the flank of the prostate gland. So you want to preserve that. So, and also we can have laparoscopic prostatectomy with perineal approach. Like I have talked about retropubic approach, right? Majority will not use perineal route, okay? Majority of the surgeons will use retropubic approach, yeah, because of the advantages that I've stated earlier. You can pause and rewind and get the advantage. Robotic assisted laparoscopic prostatectomy is gaining ground. Many establishments are using that right now. The radical prostatectomy with perineal approach, like I said, is less encouraged now. More of retropubic approach, and perineal is okay if no lymph node removal is required. So it's not completely, out of sense or out of point that you use perineal approach. What about the patient that cannot use retropubic approach? We are left with perineal approach if we still want to go through either of the route. Let me just mention some possible complications of prostatectomy. The one that I can never forget is massive bleeding. I've seen that now in those days. So hematuria is another possibility. Then damage to what we call it collateral damage to the neighbors, the close structures there. Might be urinary incontinence later on. Nerve damage, if it is not sparing, then could lead to erectile dysfunction, inability to further a child in future, fertility. There could be swelling in the penile and scrotal parts. Then fistula could also form between the rectum and the bladder. So a lot, we will discuss all these, and if you use open laparectomy and then you have prostatectomy done and you use general anesthesia, the effect of anesthetic agents, will still be there. So we'll discuss all this with the individual who needs this. When the solution remains palliative treatment only, I won't waste your time. Please click on these links to get full information about palliative treatment. When you are battling with nausea and vomiting, you get full information through this link, please. And chronic pain, you can get full information about possible interventions, medications to use, how to use them, all through these 3 links about chronic pain. When it is about infertility, please check this link. That will lead you to infertility in males and the causes and treatment. Everything is right there. Now, because we've been talking about erectile dysfunction all the while, I've listed some interventions here, but you are going to get full info about these subjects right here and here. So click on this link, go through all this, because that is the reason why many men who think they need this in their lives will not want to take any treatment. I bet you. But if you can find the way around it, then uh, once this is out of it, they may take the treatment. So go through these links, please. Now, other systems and conditions that we can be battling with would be fatigue and insomnia, about central nervous system. There may be inflammation of the rectum. The skin could be damaged. There will be hair loss, particularly those taking radiotherapy and chemotherapy. The renal system can suffer post-radiation, and I have addressed infertility and erectile dysfunction. Other conditions would be depression and anxiety. Why have I decided to bring this out? And I won't rush to conclude without addressing it. Let's face the fact. We're all humans. The man who has just passed through the stress of all the long, difficult process to diagnosis, and who had just been given the bad news that he has cancer of any sort, let alone saying cancer of the prostate. And even if he's old, he won't take it just like that. Or let me say, he might not take it just like that. And it's worse when he's just about 50 or 60 years old. No, because it's going to affect many things in his life. The next thing we should be concerned about will be anxiety and depression. So we have to have that open conversation, counseling and psychotherapy. And if we deem it fit, antidepressant or contact psychiatrist. Because the cancer may not kill the man. Your intervention may not kill the man. The man may die when depression is not handled, tilting him to suicidal thoughts, suicidal ideation, attempted suicide, and frank suicide. You see that it's pretty important to have counseling and psychotherapy and have antidepressant if that will suffice. Other medication like antiemetics, analgesics, and antidepressants will be used here. So not necessarily affecting the prostate cancer itself, but because we are dealing with a complete human being. So holistic approach is what I've presented here. In conclusion, I tie this as call to action. Prostate cancer should not be killing anyone. Please review this presentation again. I know it's pretty long, but it's going to help. Review this again. Send it to every male around you. To your dad, to your uncle, to your grandfather, great-grandfather, if you're lucky that he's still here, or great-great-grandfather, because some families will have 3 or 4 generations, your son, your half brother, and if you're a female, send it around. Your own son, your husband, your dad, that uncle of yours, nephew, all males in your life, even your male friend, send it around. And every male should be concerned, but blacks should be more concerned. Don't joke with it, please. It's not that Asians should not be concerned, but if everybody will even run away from prostatic cancer, glands should better check it before running away. Then, if you think from your family history that has been picked in the past, then you are 40 years and above today, get up, go and see your doctor. With that, I've come to the end of this necessary though long presentation about prostate cancer. The intention of having my channel is to reduce suffering and death. Help me to spread the news so that many will be educated and take appropriate action. Thanks for listening. Remember to subscribe to my channel. Remember to support my channel if you choose to. That would be greatly appreciated. Thanks. Leave a comment. Have a great day.